Expressions of interest, please. No. Okay, thank you very much. So as usual, we'll go straight into a patient story, which is very topical because it's about maternity, follows on from the Ockenden report, and it gives hopefully, well, I know it gives a rounded view of the experience in the Northampton General Maternity Unit. Debbie, I think you're running this one. Debbie, our Director of Nursing.
So Alan, unfortunately, Debbie is off sick today, so I'll be stepping in.
Okay.
So I'd like to introduce Sharon, who's kindly sharing her story with us, which is a really powerful story about it was her first baby and she was worried about the care she might receive in maternity because of articles she'd read, which is very topical, as you say, Alan, at the moment. So she received care from our continuity of carer team for Black and minority ethnic groups, and they've obviously run a Race Matters Award from the RCM this year. So she'd like to share her experience with us. So we'll hand over.
Hello, my name is Sharon. I gave birth in March of 2022, and I was a patient within the IRIS team, and I would like to tell you more about my experience and how good of a job it was being part of such a nice team. So I found I was pregnant, and as a first-time mom, not only that, I was just really worried about the patient care that I would get via NHS. Why? Because I'd seen a lot of articles and a lot of news about how, ethnic minorities have been passing away whilst giving birth or whilst they're pregnant. So later on, this workshop and meeting other midwives proved really essential, because when I went into labour, Ellie was not feeling well, unfortunately. But I met, the midwives that I'd met previously on several workshops, and it didn't feel like, I was now being handled by a stranger. It felt like, oh, no, it's part of a team. I'm part of the team. It's people that I have known throughout my whole journey of being pregnant. It's people that know my worries and people that know my story, that I've been trying to conceive for a while, and it finally happened for me. So I had the help of Martin when I was pregnant. I had the student midwife as well. And honestly, I can't sing their praises enough as a team, from Sam all the way to everyone within the team. I cannot sing their praises enough. Being pregnant is different from going to the, to A&E with a stomach ache or, a headache. Being pregnant is a journey. It's literally 9 months of your life where you're in the care and you're trying to bring, life into the world. The care is way longer than just in and out. So it needs someone that knows you, because it's a journey that you're going through. Had it not been for them, I would still have, gotten a private midwife, because comparing what my cousin has had, not even having a consistent person to deal with if she's got any questions, she's got to go to the clinic, and she might meet someone that she knows, or she might meet someone she doesn't know. She's got to explain her story several times, whereas mine, everyone knew me, everyone knew my story. It's just like, we catch up. Like, there's no need for me to explain what my ongoing story was. It was, I can't explain it enough. And, I really hope this program continues, because it did me wonders. It really did good for me. And I hope it can do good for, many more other women, because I've really had, a positive experience. It's brought my faith back into the NHS. So, yeah, thank you.
Okay. Anybody else have anything to say about that short video?
So Alan, if I can just thank Sam and Fatima for leading the continuity of care team, because they do obviously nationally recognised, but they do a fantastic job. And we are continuing with that continuity of care team, having reviewed post-doc and done, because of the importance of and the difference it makes, as we've seen in that story.
Anybody? Jill and then Elena.
Apologies, Chair. I was just going to say exactly what Heidi said. Despite the challenges of the maternity workforce, we're continuing to support the one continuity of carer team that looks after our Black and ethnic minority women, because of the importance of that. And all the research evidence tells us the outcomes are so much better when that is able to happen. And huge thank you to Sharon.
Elena?
Of course, I would like to start with thanks to our maternity team, but my question is to Heidi. How do we make sure that 100% of women get the same support throughout their 9 months journey? How do we make sure that nobody is experiencing, like her cousin has experienced when she had to repeat her story multiple times to different people? So in your assessment, these 6 stories of success, what percentage of our women get to this level of support? Thank you.
Thanks, Elena. So as you'll know, with the national challenges around continuity of care and the staffing model, it's a national challenge in terms of how we achieve the same level of continuity as we have with this team. So it's something that every unit is currently reviewing. Some units have stopped continuity completely because of staffing challenges, and we've made a conscious decision to keep this team going. So we are consciously continuing this team going because of the additional safety risks and inequalities we know that Black and minority ethnic women experience in maternity, which is well documented and well researched. If it isn't a continuity of care team, that doesn't mean they don't get continuity of community care, because we do have community midwives that try to achieve a level of continuity, and indeed sometimes that has been equitable with our continuity of care experience. However, that doesn't flow throughout the kind of pathway into labour necessarily, but it's something we're working through at the moment. Jill we will cover it a little bit later, but in terms of the future workforce model of our maternity service, but it's a challenge every maternity service is working on at the moment. And even within a continuity team, you may not always see the same midwife, but you will see one of the team. So you get that continuity. So it's a very live discussion. Our new head of midwifery started, Claire, and we're working through what do we want our workforce model to look like to allow and achieve the same level of continuity.
Okay, any other questions? No, we're obviously coming back to Ockenden later on in the agenda as quite a substantial item, so we'll pick up any other items then. Okay, minutes of the meeting on the 30th of March. Are you happy to a fair record? Jill.
Thanks, Chair. Just a minor amendment, if I may. On page 13 of the electronic pack, there's a section on the Quality Governance Committee, which talks about safeguarding training. So I wanted to clarify that safeguarding training is not new to this trust. Our clinicians have been doing this for some time. What has been difficult is that we haven't been achieving the 85% level required, although on further examination, we've discovered that Northampton has a very high standard and does more training for what we call level 3 safeguarding training, higher than expected nationally, so it doesn't compare to the intercollegiate framework, and higher than Kettering. If we measure ourselves against that framework, we are over the 85%. So our team are working at the moment to align us with national and group expectations. If you want any shortened version of those words for minutes, I'm happy to do that.
I'm sure Richard would find that very helpful. Any other comments? No, thank you very much. And the matters arise, the action report, the action log, everything is, I apologise for the dog in the background. The action log is either complete or not yet due. Okay, no comments on that? Okay. Thank you very much. Can I congratulate Becky Taylor on her substantive appointment as Group Director of Transformation and QI. Becky's with us today somewhere, bottom corner of my screen. Don't know where she is and everybody else's. Well done, Becky. And the other congratulation is probably longer in the gestation than Becky's appointment, which is Leicester University's moved 23 places up the REF scale, which is an evaluation of their research work. And that's important to us because it's part of our academic strategy and we're linking extensively. We have senior appointments to make in conjunction with Leicester at associate professor and other levels. And all of this is extremely helpful. It's a remarkable achievement to be second in the country for research in this area, second only behind Cambridge. And as somebody who's done lots of work in the past at Cambridge University, trust me, it's really hard to get past them. But you are above Oxford, which must be much easier to achieve. Okay, Andre, any comment on that, or do you just want to bask in reflected glory?
And just to add, in terms of the research, thank you, Chair. And just to add, in terms of the research output in clinical medicine, Leicester was actually top in the country. And also, as my other hat, slight conflict of interest, I'm head of the Department of Cardiovascular Sciences. We contributed more than half of the staff in clinical medicine. So, of course, the strength of cardiovascular research in Leicester has been driving some, quite a lot of that input. But thanks for giving the opportunity to flag this up. And this is great to have the ongoing collaboration with Northampton group. Thank you.
Okay, thank you very much indeed. So congratulations to you and all those in Leicester Clinical School. Group Chief Executive's report, Simon.
Morning, thanks, Alan. So as we've entered a new financial year, I thought it might be appropriate to synthesise some of the key leadership messages that are coming from the NHS at its centre. So I will give you a bit more colour on that in the private board discussion, but these are the public-facing messages. So firstly, since we last met, one of the things that everybody was really worried about was Easter. Just it feels like a while since Easter happened, but in actual fact, the hospital and the NHS more widely did much better than expected over Easter, which, given the pressures that have been on the front door, is particularly commendable. And I think it was particularly commendable given the fact that we had at that point still quite significant numbers of COVID patients in the hospital. So just to note that. But to note also, we have another 4-day bank holiday next weekend. And I just wanted to take this opportunity to say to whoever is watching us or joining us online, please do encourage all of our communities, all of your friends and relatives to use the NHS wisely but safely as we go through these celebrations. 4-day bank holidays, as we know, have particular impact, particularly when they're associated with celebrations. Secondly, it's the first time I've been able to say that COVID numbers are dropping. Now, we don't know where this is all going to go. New variants continue to come, but we are at the lowest level we have been in months, and the NHS signalled that level had tipped us over from the first time in over a year from command and control arrangements, level 4 national incident, to level 3. We are advised to remain vigilant. Local outbreaks and local problems continue to occur in different parts of the country. So although we are, and I think most hospitals have welcomed the relaxation of command and control because it gives a bit more flexibility to local systems as to how they respond, it is important that we retain that level of vigilance. Thirdly, national phrase, a window for delivery. So we have a precious few months before what we will all anticipate will be quite a difficult winter to really move forward on the delivery of cancer and elective treatments. We know that both of those teams are really busy. And although we start in a much better position than most, we need to really bank the precious few months that we've got to make sure that when we do get to winter, which will be difficult, we have done the very best we can by that stage. Clearly, in parallel with that, we will also be pushing forward on our transformation agenda. And I think it will be important that we take the opportunity of those precious few months, not just to focus purely on delivery, but also to focus on some of the changes that we need to make that will enhance delivery as we go forward. Fourthly, money matters. So we've had nearly 2 years, just over 2 years, where money has not been part of the conversation. It now is again. All organisations grew COVID fat in the period of the last 2 years. In short, because we were running duplicate pathways all over the hospital. We now have to find a way of taking that fat back out and pivoting the NHS back to a more normal pre-COVID operating model. We have a significant challenge, and that challenge is a national one, I would hasten to add. We are still not yet agreed with NHSC what our final plan is. You will hear an update from John today on where we are, but it is going to be a real test of system working to make that a success. And Alan and I expect to attend a special session of the ICB board to discuss the system plan. We are required to resubmit a final plan on the 20th of June. Fifth, transformation has been highlighted as key to improving productivity. That's an immense topic area in its own right, but I just wanted to note 2 areas, both of which we have in sight. And the first is that the connectivity at a system level, our digital system agenda, is really key. I'd like to thank Andy for his recent presentation to the ICB. It has provoked quite a lot of discussion amongst the system about what do we need to do and how do we accelerate the progress really to drive some of that productivity. I would expect us to be coming forward with some quite bold proposals as a system to be considered at the ICB on a much more shared service basis than we have in the past. This morning, the HSJ, for those who have not yet read it, was highlighting the trusts that have still yet to get a full EPR. Northampton was obviously named amongst those trusts. That is a list I'm quite glad we are on, if I'm honest, because it highlights the need that we need to make progress on that during this year. The issues are not our endeavour. The issues are the funding streams being connected to local delivery. But I am confident that with Andy's help, we will make progress on that during the course of this year. And finally, in the area of transformation, just to highlight these areas of virtual wards, there is funding associated with this, but the NHS cannot fundamentally grow its bed base, nor should it, but it can grow virtual wards. And so I think particularly in the areas of admission avoidance around frailty and respiratory, we will be expected to make progress this year. I've shared with you the staff engagement People Pulse survey summary, and I just wanted to draw out one point here. It is that the cost of living increase is now a feature and becoming rapidly quite a dominant feature for our staff. It was mentioned in our most recent People Pulse survey over 200 times. I would expect those issues to continue to grow as the year goes on. We shared at our last group briefing, and I have repeated for you here, some of the things that we are doing across both hospitals to really try and help people. We've managed to retain free car parking, and you can see the other issues. The free car parking was very welcome, but you can see the other areas where we are trying to make an offer to staff and make it visible and accessible to them. But I think there's a challenge for us all about, have we done as much as we can? Do we need to do more? there is no doubt that some of our most junior staff and some who are on the lowest levels of salary will be finding this really hard. Finally, I just want to highlight the cardiology workshop. It was a very successful workshop, and it really shows the opportunities that exist when we start to think about clinical collaboration. It was, I think, summarised by people who attended it as 2 teams came into the room and 1 team left the room. And I think that's a really good way of framing it. So our challenge is really to realise that opportunity, and obviously all of us will be involved in that. Thanks very much.
Thank you. We'll take comments on that together with Heidi's one. Heidi, over to you, please.
Thanks, Chair. I'll take the report as read, but a few things I wanted to pull out. So following on from the staff survey and the pressures that Simon described our teams will be under, I just wanted to highlight, obviously the staff survey has shown a consistent areas for us to improve in Northampton, and there's a significant piece of work underway both across the group and Northampton specifically to look at what we need to do to improve our culture. There are some really good pockets within the staff survey, but there are some areas we absolutely need to make a step change in supporting teams to be happier at work and bring them feel as valued as they should. So we're doing a lot with the teams as an executive team and the divisions, and we're doing a lot of engagement, listening, really making sure we close the loop on understanding what the challenges are and what will make the biggest difference to frontline teams. So there's a significant piece of work there underway. Can answer questions if people would like to know more. Obviously it's linked to reward and recognition and people feeling valued as a whole person and valuing the diversity of our teams. Would like to also highlight the nursing conference. So we had a nursing conference to launch our pathway to excellence, which will be going for redesignation later this year or early next year. The energy in the room, the passion in the room and the united purpose was really profound. Jill was there as our NED. She may want to comment on it, but it was a really powerful demonstration of the value of bringing people together and really talking about what they collectively need to achieve. So that was the start of us really tied to the cultural work, but really looking at what our nursing and AHPs and nursing associate teams can achieve and our midwives. So that was a really successful day, along with International Nursing's Day and International Midwives Day. So maternity we will be covering later, so I'll cover maternity when we cover the Ockenden report, if that's okay. Urgent care, I wanted to pull out the work that's happening there and flow through the hospital. So as you'll know, we're obviously remaining challenged, although we have reduced our escalation status at times, but it's still very challenged as a team. There's a number of pieces of work we're doing, both to make sure we're benchmarking, working with partners. So we've invited a number of external reviews from our ESIST, the Emergency Care Intensive Support team from NHSEI, and our teams are looking at other units. So we've done along the whole pathway a number of pieces of work to make sure we really start to get this journey right and try to drive the improvements in a sustainable manner. We've also been recognised for some of the excellent work. So our SDEC team have been recognised to be one of the best in the country in terms of the work that they're doing. So people have come to visit that. But there's no doubt that it's still very challenged in our urgent care pathway, and there's some work we need to really get on top of ahead of winter. Some of that I'd like to pull out is the GIRFT report showed we had a significant gap in terms of estate. So it showed that we had around 8 majors less than we need for the activity we're seeing. So we're in conversations with the system around what that means in terms of pathways ahead of next winter, and certainly a discussion around we don't have an urgent treatment centre in the west of the county, and we still don't have a plan for that. So that is something that Simon and I are talking to the system about very currently, very robustly, in terms of the need for that ahead of winter. Equally, some of the transformation work that Becky's leading on is really helpfully driving the need for live capacity dashboards, and part of the national discharge work that we're part of is helping us have that conversation. So we welcome being part of the national discharge work, the 14 trusts that we've updated before, so I won't go into that. Some positive things I just wanted to bring out. Our pharmacy robot is finally in place, so that brings some real benefits for our pharmacy team and our wards in terms of medications, which Matt I'm sure will cover later, but we've successfully bid to be a clinical research facility from the autumn. So that's something to really take a moment to celebrate. And also we're launching a robot competition with our county and our schools to really celebrate us getting the robot here, because obviously it's important that we recognise the impact on the county and try and work with our public to really celebrate the things that are going well. So they're the things I wanted to pull out. Any questions? Happy to take them.
Okay, any questions or comments on that? The NIHR clinical research facility is quite a coup, really. They're not easy to come by, and it was a highly competitive process. So well done to people who did that. David, and then Jill, please.
Yeah, thank you very much, Heidi. It's great to hear some of the positive stuff that we're doing in the hospital. But as you say, urgent care pathway does remain challenging. So my first, and it's also good to hear that you are having conversations with the system about estates and about how we can expand the current facilities for 8 more major cubicles, and I think we'll be interested to hear that as that discussion progresses. 2 specific questions, one on the urgent care. First, about the National Discharge Programme. What specifically is that doing to help us in the issues we have with flow? And my second question is around the not the urgent care unit, the intensive care unit. When are we going to see the intensive care unit open?
Okay, so Simon, I don't know if you want to come in on the first question, or do you want me to cover that?
I'm happy to start, Heidi, and then I'm sure we'll do a double up. So, David, this programme is made up of 4 strands, ranging from hospital through to specialist rehab, community, and step-down care. So we are part of the hospital stream. So we had our last session a couple of weeks ago across the system. This was the first time, and the thing I want to highlight here, David, is that hospital flow is integrally related, as you well know, to how the system is working together. So the chief exec who leads this, Leslie Watts, who's the chief exec of Chelsea and Westminster, had all the system colleagues in the room to challenge them on how you are supporting flow across the system. So this went everything from where ambulances could divert to alternative care pathways, right through to what social care could do to pull patients out of the hospital. The biggest thing we probably need to do is that the hospital programme is in advance of some of those other strands, and I have asked Leslie for the support in making sure that all 4 strands are operating in our county simultaneously, because it's when we get that synergistic benefit we will see the kind of real transformation around some of the issues that we consistently experience, and she has committed to do that. I'm sure Heidi will want to say something about the work that we're doing in the hospital, because there is still work that we need to do, as well as work we need to ask our partners to do.
Yeah, thanks, Simon. So just sticking with the system initially. So one of the real challenges we have, David, is having real system oversight of the capacity we have to allow us to respond in periods of escalation and challenge. So that's something that piece of work is helping us focus on. And Leslie was really helpful in the meeting last week or the week before, as Simon referred to. So we're one of the streams. I will bring Palmer in because Palmer's largely leading on it, and he will be able to give us some very specific narrative around, which I think would be really helpful. But I think this is where there are things that the system needs to do, and our confidence of admission avoidance and patients being pulled out of the hospital, because obviously that when they're in the hospital, they're deconditioning, and it isn't the best place for patients once they no longer need acute care. So there's very real, robust conversations happening with the system, and that piece of work really helps us do that. So we really welcome it. Within the hospital, however, there's things we can do where patients are coming into our ED and perhaps don't need to see an ED consultant and could be streamed in a different way. So we're looking at and have introduced from the front door different pathways into our RESDEC. Same day emergency care unit, sorry, using abbreviations. And so we're really looking at, and like I say, that's been recognised, that the streaming that we're doing into there is something that is one of the best in the country. We're also looking at how we use our acute medical unit much better, and our medical take model in terms of how patients are owned within the medical workforce. And then we've just introduced actually some patient flow coordinators, which have seen a reduction in length of stay over the last few weeks, which is quite significant, reduced by 3 days. Palmer may come in and correct me, but I'm sure it's 3 days. And so we're hoping to see all that obviously sustained, but we are seeing improvements, and we're seeing the work that we're doing across the whole pathway starting to really show some improvement. So it's really making sure we're unpicking everything we can do too, to make sure we concentrate on pathway 0, which is patients that don't need to go out with a package of care, and that we get patients out and utilise productively the time that they have here. Palmer, do you want to add anything else, or are you?
I think just to add 2 key steps that have really made a change. Diagnostics, we have driven a lot of change there to enable us to make quicker decisions on a daily basis, so we don't have a lag of patients waiting for CT, MRI and ultrasound for up to 2 days. So it's now usually on the same day, if not the following morning, before the next board rounds. Frailty now has the unit back up and running, and that's making an enormous difference, because we're turning around at the moment 4 patients a day going home straight from it. That means that actually those patients would probably have stayed on a base ward and ended up being in our stranded and super stranded numbers. So whilst the daily number is small, the effect on the larger scale is huge. And the last bit is just, when you look at the trends, we're up by 2,000 people coming into ED over the last 90 days or 3 months compared to 3 months before. We're up in terms of the numbers waiting for packages going out of the system, but we are down in terms of our length of stay, our admission rates. So those who come through the front door, the percentage of those that we're admitting has gone down by 3%. So from 19 to 15% in A&E overall in a whole trust, from just over 23% to 20. So it's a huge amount of work that's been done across all teams, from front of house to back and support.
Yeah, it's good to hear that we are getting some positive outcomes from all the work that's going into this, and long may that continue.
Jill, and then I'm sure Stuart will answer on the ITU handover. Jill.
Thank you, Chair. A couple of things, if I may. First is to reinforce what Heidi said about the conference that was held on the 10th of May. It's the first time we've been able to have such a conference since the pandemic, and it's really important that we celebrate the successes and the work that our nurses, midwives and nursing associates do. I was completely blown away by the presentations, and we also made presentations to them to recognise those achievements, and also to say that we were supported by Northamptonshire charities. The theme of the day was being proud of working at Northampton General Hospital as a nurse, midwife or nursing associate. We gave away bottles which said that, don't know if you can see that, water bottles. It was very well received, and I think this kind of event is really going to help us in relation to recruitment and retention of this workforce, and also one of the many things that we should continue to do as part of improving our staff survey, and I know we've got a paper on that later. And then secondly, in terms of urgent care, just to say, in the Quality Governance Committee, we're increasing our focus on that pathway, because we know nationally there's been a lot of media attention in relation, and quite rightly, to ambulance handovers, pressure on ambulance services, overcrowding in A&E. So we've been asking how we can be assured that our patients are safe in that environment. And we've been getting that assurance, and we will continue to ask the questions. Thank you.
Stuart.
Thank you, Chair. Yeah, David, we're in the final stages now of the ICU, so all the internal work is complete. We're into the testing and commissioning of the systems. It's a complex building, so they are well underway now, and we've in fact started our own internal commissioning now with the clinical teams. So I think their training starts, I think it's the 8th of June, where they're going to start setting up test runs and training. So in answer to your question, end of June, we will be patient ready. So end of June, we'll be ready to transfer patients in there.
It's been a long haul, Stuart, and I know it is a complicated department, of course it is, but it has been a particularly long haul, this one, and many of the problems being contractor materials availability and other things, but it's good we've got there in the end, but it has been slightly disappointing in the process. Okay, anything else though? Nope, thank you very much. The Integrated Governance Report, known as the IGR. I think it's Andy first, and then if you could hand straight over to Heidi to compare the session through no doubt very crisp reports from all the committee chairs and executives that focus on exactly what they want to tell the board, and recognise that's the purpose of this report. Okay, thank you. Andy, then Heidi.
Thanks, Chair. And I'll just take a moment to sort of give it perhaps a bit more depth this month, just to give colleagues an indication of where we are. So this month, the number of metrics in the IGR is increased by 2. There's more narrative being added in this month as well, and there's more to do. There's a couple of things in the report I'd like to draw your attention to. So you'll see the number of metrics that are still working through definition. So 57 of the 89 have been defined, and the packs identify those in red, which are still working to get an agreed definition. We're continuing to work with the executive and operational teams on a one-to-one basis to work that through. And we'll also be asking the executive leads to work with committee chairs to prioritise which are the most important metrics to have next. As you'll see in the report, we think it'll take a further 3 months to get the metrics fully defined and data flows in place, and then a further month to refine the visualization. So the September board is when you should look forward to having the full set of agreed metrics in the IGR. I guess there's a few other things I wanted to say in the context of this, and you'll see the timeline of how the report comes together, which gives some background on why this whole thing is pretty challenging. There's actually only 2 days for a final review and sign off of this report, which, as you can imagine, is pretty tricky when we've got operational pressures as we have of late. And a review of other NHS boards show that majority actually use data that's 1 month in arrears. Now, obviously, that comes with a downside, and I think this trade-off between the currency of data and the time for the analysis is probably something we'll need to come back to in the next few months. But I think it's important that colleagues understand, some of this stuff really does happen quite late in the cycle for good reason. And the final thing I want, regarding the IGR, I want to highlight the next iteration of the look and feel. You'll see in the appendix the next version that's coming next month. This has been based on feedback so far. I hope you agree this represents another step forward, and thanks for the feedback in that. Just as I finish, I think I just want to thank you for your patience as we work through the IGR development. But what view should you form from this? Across the whole hospital, is it all doom and gloom? It's absolutely not. And I don't want the board to take the challenges of developing the IGR as an indicator that our organisation is running blind in terms of data. It's very far from it. And this week, colleagues, I've shared a short report with you that shows that our teams across the group complete nearly 5,000 statutory returns each year and provide over 150 real-time or regular reports to support operational decision-making, and continue to work their way through a large number of ad hoc requests. So yes, the team is challenged to meet demand. And yes, we do need to invest in the transformation of how we deliver health intelligence. And I'd like to assure the board that this is very much at the top of my priorities and working really hard to address it. Over to you, Heidi. Thank you.
Thanks, Andy, and thanks for you and all your team's hard work on it, working with our teams and acknowledging the tight turnaround. I'll go straight into Quality Governance Committee. Actually, before that, I think it's important to acknowledge your point, Andy, about there's a lot of positive things in the IGR, as well as the challenges that we often focus a bit more on. So that will hopefully come through in some of the committee's updates. So I'll hand straight over to you, Andre, for Quality Governance Committee, and then Matt can come in after Andre.
Thanks, Heidi. So we had a meeting last week, the Quality Governance Committee, and I think we acknowledged that the IGR is a work in progress and it's probably not a state that is particularly useful for the committee in the current rendition, but we are hopeful that it will be in the near future. Obviously, the committee paperwork is quite a big tome of data with large volume of data and a multitude of themes that make deep discussions rather challenging for the committee, because obviously the committee members, especially the non-execs, are mindful that our main purpose is to provide assurance for a lot of the quality and safety metrics and on a governance perspective. So we feel that we would like to provide a higher level of that, but we do acknowledge that the quality reports that are produced by the nursing director and medical directors are of a quality that we are able to have useful discussion at the committee meeting. Moving forward, we have agreed that we would have a timeout with the exec team to map out the content, volume, and perhaps the timing of our committee, whether we needed to extend the time of our committee meetings or stagger discussion themes so that during the committee meeting we can have quality discussion and provide that high level of assurance that I think as NETS we would like to provide for the board and the trust. So there are a lot of metrics for us to look at. So I think we need to agree on what those metrics are and prioritize which ones are important. We acknowledge that there are some difficult areas. Maternity staffing continue to be an issue. And we know that there are plans to try and address that from various angles. We noted the security management annual report, which was of significance. And I think we would like to thank all the security team in their hard work in that area. So I think just to summarize, there's a lot of engagement, and I think the non-execs would like to provide better support for the trust and also assurance. But I think we do need to map out our workload and also the volume data that we need to handle. So I think I'll probably stop there and welcome any input from Matt and Heidi yourself.
Thank you, Andre. Heidi, Chair. Little to add really, other than to say to appreciate the kind feedback in relation to the quality of the reports provided by clinical colleagues at the Quality Governance Committee. And as you rightly allude to, it does allow us the opportunity to land on some of the good work and the good news that we are able to share. Mindful of the Chair's steer to be crisp and succinct, I will just pick one that we have achieved and retained a better than expected mortality at this trust, leaving us best in our peer group of hospitals, for instance. And so it is helpful to note that whilst the IGR remains a work in progress, we are using quality reports alongside that to mitigate any impact of that. Thank you.
Thanks, Matt. Whilst you said that very briefly, I think given the impact on patients, it's important for the board to note that sustained improvement in mortality. And thank you for all your hard work on that. Jill.
Thank you. I just wanted to reference the group Clinical Quality, Safety and Performance Committee. There is a statement in there which says maternity safety has been identified as a cause for concern with mitigations. And as a standalone sentence, that looks quite worrying, but it's actually referencing what we've already discussed, which is the staffing challenges that we have. In fact, Kettering Hospital, as part of our group, have exactly the same challenges, but the gaps are in a slightly different place. The only other thing that we have that's over and above what's already happening at Kettering is that we are doing a big OD project called Building Tomorrow Together, which is to really enhance the culture within maternity services. A huge mitigation, because as we know, a good culture is an integral part of patient safety. So I just wanted to say a little bit more about that as it's referenced in the pack.
Thanks, Jill. Really helpful, and as you say, really crucial work given the cultural journey that our maternity service is on. So thank you. Any other questions for Andre, Matt? No? So I'll move on to Finance and Performance Committee and bring in Rachel, and then any additional comments from John or Palmer.
Thanks, Heidi. This update covers April and May's meetings. The one point to bring to your attention for April is the year-end position. So the trust ended the year with a surplus of 0.4 million, which is 0.4 million better than the break-even plan. In relation to the forecast deficit of 0.7 million, the position's better by 1.1, which largely relates to the annual leave accrual reduction. Capital spend as well closed at 27 million against a revised plan of 27.5 million, which is pretty good considering how much of that was received very late in the day. Moving on to May's meeting, pulling out the key points from estates, we discussed the decarbonisation scheme, which, just as a reminder, is a £26 million scheme, of which we need to spend 10.8 million this year. And I'm sure John will correct me if I'm not right on that. We do have a programme lead starting next week who can manage this. It's a rather large sum of money to spend, and we need to make sure we spend it wisely. The biggest challenge here, I think, is the risk around the supply chain, price increases, availability. But I think the other thing that we need to make sure we do is the benefits realisation. So we did spend some time on that. And also when it comes to the business cases, which was the next point we discussed. We had assurance from Becky Taylor that actually all of these schemes, transformation efficiencies, projects, and business cases are in the process, or most of them have been gathered into one place. So we should be able, from a financial and productivity point of view, have oversight of these sometime, I think, Becky, and you can correct me there if I'm wrong, probably June to start with. It may not be perfect, but actually I think we need to make sure that we land so many of these, or if not all of them, this year, given the challenging financial place that we are going to find ourselves in. We also, on the business cases, so we supported those, but under the proviso that maybe they need another further review given the operational plan challenges, which I know John is going to go into later. So support, but maybe not start straight away. We also had a discussion on actually with those business cases, considering they've been prioritised and scrutinised by the divisions, and these are the ones they've ended up at. Actually, what are the risks of not pursuing some of these? So maybe the next phase is to take another look at them, and maybe we need to reprioritise these. I'm not going to pick up on the planning round because, John, I'm assuming you're going to be doing that. On performance, as Palmer and Heidi have alluded to, we have, under some very challenging environments, improved our performance in a number of areas. We have increased referrals, we have, especially for cancer. However, the number of treatments has gone up 13% in a month, and there's a real push to keep overachieving on the 28-day faster diagnosis standard. The super stranded numbers continue to be high, and obviously urgent care is exceptionally busy, but we are seeing signs that with reduced admission rates and reduced length of stay, we are holding our own. However, there is a lot more to go at on that one. So given that Palmer has been in post probably only a couple of months now, and I can't actually remember when he started, Palmer, but his drive and enthusiasm is really, and attention to detail is really starting to pay off. So I would like to thank him. And that's me concluded, Heidi.
Thanks, Rachel. So I'll bring John in. I'd also like to share his thanks, given he's had a baby in that time as well. Well, his wife has. He's really brought a level of focus working with the team. And so I'll bring in John now.
Thanks, Heidi. Thanks, Rachel. So, so to kind of add my view on year end, clearly subject to audit, I will always say that. I was very pleased with the performance that we landed materially. We were in line with our forecast and in line with break even, both for revenue and in terms of spending all of monies. That doesn't go without concerted effort across a number of teams. So a big thanks to all the teams, in particular digital and estates, to make that capital position land where it did for the benefit of our patients as we move forward. On the revenue position in year, so we are broadly in line with, well, we are in line with plan in month one, a deficit of £1.8 million. The only due to a number of ups and downs around income and pay, which broadly net off. I will say that from a workforce reporting point of view, our workforce numbers have dropped a bit compared to last year, circa 50 compared to February. I'll compare to February than March because we normally see a spike in March. And we're working through the reasons for that, expected due to the reduction in operational pressures and availability pressures as we kind of move out of COVID disruption. And I should probably say that clearly is a month one plan versus the plan that we submitted as part of our system plan in April, and a number of comments have already been made around our need to relook at that as we move forward for a further submission at the end of June. So nothing else to add other than that. Thank you.
Thanks, John. And Palmer.
Thanks, and thank you, Rachel. Just one thing to add is just the cancer performance. Whilst nationally it is very difficult, our 2-week waits are still first in the region. Our 28 days past the diagnosis is third in the region. And our 62-day, which is ultimately the most important when we treat people, is fourth in the region. So whilst the numbers change, we are constantly doing a lot. We are still hitting way above our weight in terms of the region and also nationally. And that is really impressive for the clinical teams, especially, who are driving the changes, because cancer is absolutely relentless in terms of the focus on detail that they need. So it's, I think when everyone looks at this, they would assume we've taken something out of elective care by what we're achieving on our non-elective and our flow. Actually, we haven't. We keep driving it, and we're hoping to try and hit that kind of 100 to 104% for the elective recovery fund on our activity numbers and things like that. So it's just a kind of thank you to the teams that are doing that.
Thanks, Palmer. And I think, again, it is important to acknowledge that whilst we talk about the urgent care pathway, our teams have managed to sustain a really positive position in our elective pathway and our cancer performance. So obviously they all go hand in hand in terms of the pressures. I'll bring Simon in now.
Thanks. Just to say, we had our QSRM last Friday, again, to explain the acronym. It's the quarterly system review meeting, which we meet with our regulators to get their assessment of where we are. Our performance as a system was commended on all of the issues that Palmer has raised. We sit in a pretty good place on all the cancer standards, which is not the same elsewhere, just to say that. And so I think one of the challenges that we're going to get into, particularly as we start to have the discussions around money, is how do we balance the assets that we've managed to accrue in terms of that real performance gain with the financial challenge that is now upon us. Pretty much every performance metric that was mentioned, our regional director Dale was impressed, so I just wanted to feed that back and again support the commendation for the work that is going on.
Thanks, Simon. Really appreciate that, and really important to acknowledge the point Rachel made of the hard work our estates team are doing at the moment as well. There's a lot going on in that team and a lot of positive improvements from a quality perspective and driving some really big things forward. So thanks to them as well as everyone in the hospital for the hard work on the things we've just described. So I'll move over to Denise for our People Committee and then Mark.
Thanks very much, Heidi. Yeah, People Committee, I think they can be summarised by the fact that there is a lot of really great action being taken, but we do still have a number of areas of concern. In terms of the People Performance Report, absences reduced slightly, but they are still running at around double our target. So the absence rate is something that we're monitoring very closely. Likewise, turnover. And vacancy rates, whilst we're averaging vacancy rates, I think around 9% in some parts of the hospital, those are and have been up to around 20%. So that obviously has a massive impact. And the other area that we focused on at committee was around appraisals completion, which is still below target. There is a work underway on a new appraisal process. And we have asked for an update on the process at the next meeting, because it is recognised that there is a link here between this appraisal completion and some of the other things that I'll come on to now around reward and benefit. So health and wellbeing and reward and benefit, there was a strong focus on this at the committee. Again, a high number of initiatives and a lot of really hard work going into this from Mark and the team and more widely as well. We did gain assurance at the committee that as a hospital, we are looking externally as well to ensure that we're learning from others and to reflect sort of good practice elsewhere. And we are carrying out what I would term as impact reviews and looking at what are the benefits, what are the things that people are taking up. So there is work underway to make sure that the initiatives that we've got out there are the initiatives that staff need, and that's an ongoing conversation. In spite of this, it was disappointing to note that in the Pulse survey, the sort of headline in terms of how are you doing right now question, there has been no change on that since last September. And the main areas of concern in terms of the themes coming out of the Pulse survey continue to be line management, activity and quality, and increasingly reward and recognition as well. Simon asked the question as part of his presentation around have we done everything that we can do, and that was a real focus for the committee. There's a reward and benefit task group has been established, and we've asked for updates at each committee meeting now. And a continued review, as I've said, of the benefits that are being taken up. This review, in particular, we focused on the VIVUP discount scheme, and that is indicating that the behaviour is starting to change in terms of, whereas it would previously have been the case that staff are searching for sort of electrical items, if you like, in discounts, there are now increasing searches for personal loans and supermarket vouchers. So again, this is something that we're watching carefully, and we are also in the process of establishing food hubs, which I guess is the equivalent of food bank for staff in need. In terms of the workforce plan, I'm not going to say too much about that because I think that's going to come in to the operational plan discussions. Our discussion did acknowledge that changes need to be made, and also acknowledge the fact that productivity really needs to be a key focus for the committee moving forward, and a new task and finish group has been established around productivity, and that was discussed at Finance Committee as well. And then lastly, on the safer staffing side of things, we did acknowledge all the great work that's gone on there. When you looked at the safer staffing grid, it is primarily a sea of greens. There were a few reds, but not very many. So we acknowledged all of the great work that's gone in on that. We did acknowledge also, however, that there's more work to do in terms of considering this balance between productivity and the cost of this, and that will obviously align closely to the workforce planning. Thank you.
Thanks, Denise. Mark, anything you want to add to that?
Thanks, Heidi. So two really quick things, and thank you, Denise. So one of them is with regards to vacancy and turnover, and just as building upon that, if Debbie was here today, she'd also want me to acknowledge that we had a recruitment event that was held the week before last, which was hugely successful, with over 100 offer letters being produced, and colleagues that will then come and join us. That was really positive. That's particularly in some of our areas such as our healthcare support worker roles, where we've seen high turnover recently, and it's important for us not just to attract people and to bring them into the organisation, but to induct them well and make sure they have a positive experience. And the second part that I would like to raise is just around, and I know it's on item 10 of the agenda, but around our board assurance framework. So in June, we're going to take that for our committee development session and have a real go through that now, as we've been a joint committee for a while, and we need to make sure that our BAF reflects that. Thank you.
Thanks, Denise and Mark, really helpful. And just to acknowledge, all our teams are working really collectively, collaboratively on this work. So thank you for I can't thank your teams enough. Any questions at all? No? So thank you both. So we'll move on to digital and hand over to Andy and David. Normally Andy comes in actually, but David, did you want to come in or?
Yeah, thank you very much, Heidi. You have the report there, and I think there are 3 items which I would like to highlight. And the first one is one that Simon alluded to during his report, and that concerns the implementation of an electronic patient record for Northampton. And the whereas the committee was glad to hear that the EPR is moving forward for various reasons. I mean, the issue is, well, the upside is that we have more money. The downside is that we would not expect to see an EPR implemented in Northampton until about 2025. And, that's a long way down the road. And what can we do in the meantime was one of the challenges that the committee made, and how can we shorten those timeframes? I think the second issue is the Northampton care record, and this is more of a system issue, really. I mean, the Northampton care record is something which has been talked about for, I think, more than a couple of years now, and that still hasn't been implemented. I think there is light at the end of the tunnel. Andy will probably be able to give us some more flavour around that when I've finished. And the third item is something which I think is really good news for Northampton General Hospital. It's the Automation Accelerator Business Plan, which was approved by the Digital Committee. And the Automation Accelerator is something which is run by a guy we know at the board, by Tremaine. And it's basically a business plan to roll out a centre of excellence for robotic process automation, which will not only assist the group and both the hospitals within the group, but is also going to be actually selling its products to other hospitals in the NHS and other organisations within the NHS. And I think that speaks a lot, not only for Tremaine and his group and Andy and his group, but also for the hospital, and a lot of credibility there. So they're the 3 things I want to highlight. Over to you, Andy.
Yeah, thanks, David. I'll just pick up on the NCR. So at the NCR board this week, we talked about the ways it would get forward from the impasse about going live, and the board set itself the challenge that when we meet in June, that we would be celebrating going live. And so we proceed over the next few months on that basis to look forward to that happening. There's a number of things that have been a challenge that have now been resolved, and we had clinicians on the call talking about how one of the compromises regarding allergies would be able to proceed on a safe basis. So I think we're in a better position than we were when I talked last time, and certainly since we talked at the Digital Hospital Committee. Yeah, I'll just add to your comment about the Automation Accelerator. I think we're one of the 2 centres of excellence in the whole of the NHS regarding this, and reputationally it does us really good. Thank you.
Thanks, Andy. Thanks, David. Yeah, I'd just like to acknowledge the work Tremaine's doing. A lot of people are talking about it with pride. So on the theme of the nursing theme, what makes us proud, a lot of people are talking about that. So it's important to note the ambition in the digital space that you have. Elena.
Thank you, Heidi. The question is probably for Andy. I appreciate that this committee, the Digital Committee, also pays lots of attention into the progress in terms of IGR maturity. So I appreciate that data of the high quality and visualizations are very important. But another super important component of the successful IGR is data interpretation, converting into intelligence and actions. How would you assess commitment at the operating and executive level to drive IGR maturity? And why does it look that KGH is ahead of NGH in terms of commentary? Is it related to the policies and procedures over managing data in commentary? What is it due to? Thank you.
Thanks, Elena. Yeah, so as I talked about, the time for making those commentary is quite narrow. There's been great efforts from all executives from both organisations to try and collect the narrative and get it in place. And so I don't think I can point the finger at anybody who's not trying to do their best in this. It's just a challenging process given that time window, particularly when there's other things on the cards. And so, we'll continue to work with the executives and the contributors to, really ensure that there's a clear understanding of what's expected as we go into the next cycle for the IGR.
Thanks, Andy. And Elena, I think just to assure you, obviously this is something that I've picked up and we discussed this. Some of it is about the journey we're on. Kettering have worked on some of this for slightly longer, and some of it is pulling it so they're in the system of doing this work. And some of it is simply we are on the journey and the allocation of metrics being allocated to people in a timely way. So we're working really closely with Andy and team to make sure the timeliness and the allocation is as slick as it can be. But as Andy said, we're being very ambitious in terms of looking at the real month time, so it gives a very tight window. But it's something we're definitely focusing on at the moment, currently ahead of the next committees as the journey of the IGR progresses.
Thank you for this assurance, Heidi, because it's not only up to our IT colleagues and informatic colleagues, it's so much input from operating and executive colleagues. That's what will make IGR a more valuable thing than it is now. Thank you.
Absolutely, but they obviously need to be allocated to the right people, etc. So it is a journey, and it's a two-way collaborative process that we're working really closely on in a really positive way. So hopefully next month you will see a big difference in that. Simon.
Elena, your question's a really good one, and Alan and I alluded to it in my report, but I think it might be helpful for non-execs to see the system context and see the presentation that Andy did to the ICB, because most of the points that you've just made are issues across the system. So I think the equivalent of the IGR for the system has been identified as a real strategic weakness at the moment. And I think it's something, I'm sure Alan can speak for himself in terms of that report and what we thought about it. We thought it was a good opening discussion, I think. But there's a huge agenda across the system in this space as well. So the NARP, the Northamptonshire Analytics Programme, is another key thing for us to get right. And it's going to be particularly critical in terms of getting us ready for winter, so that we have one version of the truth in terms of, Heidi's already alluded to this, system capacity, because up until now, that has been a real struggle, getting the shared care record to go live, because that will help us with the admission avoidance, and basically starting not just to build analytical capability in each individual organisation, but actually for the first time in Northamptonshire, which is why your question is such a good one, getting capability across the system, and then using that to conclude with your words, to create actionable insight. So I would encourage us all, and if people would like to see it, we'll circulate the slides that were taken to the ICB, because everybody in Northamptonshire is struggling with this at the moment in one way or another. Thank you.
Thanks, Simon. And Elena, as part of the away session that Andre described, will pick this up as well to make sure we're all clear on what's the most beneficial use of the resources that we have. So moving on, if there's no more questions, to Rachel for CPC and Simon.
Thank you. So again, this covers April and May's meeting. April's meeting was predominantly looking at reviewing the progress on the strategies, clinical strategy, group digital strategy, and the academic strategy. I think the point to make to the board is that the latter, the huge progress made on the academic strategy. The patient recruitment target has been met with over 3,000 patients recruited across Northamptonshire for research, which is a huge thing. And actually, it not only helps our patients, but also helps our reputation and therefore our attractiveness as an organisation or an employer of choice. May's meeting, two themes there. One was the progress on integrated care system. We had a long debate about how much appetite we had for leading certain work streams, contributing or merely influencing. And I know that that's been taken away for review and will return at some point. I think the main points to make on the estates review are around the progress we've made on looking at the cost-saving opportunities that the group brings. So we had a specialist report commissioned, which came up with a number of areas for consideration where we could harness the capability as a group rather than two individual hospitals. There's a few questions around these, as in how do we ensure that these savings are actually tangible? Where's the substance amongst these? Also noted that it requires significant cultural change within the teams. And actually, what's our risk appetite as a group to tackle some of these and actually land them? So there is ongoing work there, and the next level of detail is required to really scrutinise these. So we're looking forward to that. Thank you. That's me done. Over to Simon.
Thanks, Rachel. Nothing to add. In the interests of succinctness, again, I will be succinct. I can see I'm getting a nod from the chair, so there we are. I'll pass on.
I was about to point out we were close to time. Thanks, Simon. Any questions? No. So we'll move on to you again, David, for the Audit Committee, please.
Thank you very much, Heidi. Yeah, the audit committee met on April the 25th, and it met with a harmonised agenda with the KGH audit committee as previously agreed. And also as previously agreed, it met on the same day as the KGH audit committee, and I also attended the KGH audit committee as an observer. Sure, as Richard and John will attest, attending 2 audit committees in one day is actually quite challenging. Anyway, as the board is aware, the committee is to ensure that the trust has in place effective governance, internal controls and risk management. So items to note from the meeting which took place on the 25th. An annual report was received from TIAA. For those who don't know, TIAA oversees the internal controls for the trust, and the annual report concluded that TIAA was satisfied that for the areas they reviewed during the year, the trust has reasonable and effective risk management control and governance process in place. So I think that's a reasonable thing. The committee reviewed corrective action carried out on priority 1 and priority 2 recommendations, which had been raised by TIAA as a result of their internal control reports. It concluded that there was merit to a process undertaken at KGH, where recommendations are allocated to specific EDs for corrective action, and indeed to board committees for scrutiny where recommendations are not corrected on time. Similarly, a report was received from TIAA on the job they do with respect to fraud awareness, and the committee emphasised the priority that had to be placed on ensuring high levels of training and awareness in this critical area. Moving on, the committee heard from its external auditors. External auditors are Grant Thornton, who are on target in terms of preparation of annual accounts and were working well with the finance team, which was good to hear. A report from the group CFO was received on potential accounting issues, and we also received a draft of the annual accounts, which were those expected to be signed off by Grant Thornton. A draft of the annual report was reviewed, and I think another board meeting today will also look at that. The committee did note that a page-turning exercise to review this report, and indeed the quality report, may be advisable prior to presentation to the next audit committee. We felt that this would ensure a more structured and thorough review of these extensive documents, which will be in the public domain. And I believe such a session is going to be arranged for members of the audit committee before the next formal audit committee meeting. The committee reviewed the BAF, and that's the Board Assurance Framework, and the Corporate Risk Register, and raised a number of concerns concerning harmonisation with KGH was one, but was assured that work was underway by our governance teams to review the processes that generate both these tools, which are absolutely crucial and do underpin the trust's internal governance and risk management arrangements. Finally, terms of reference, the committee reviewed or revised a certain number of revisions to the committee's terms of reference, and it did recommend approval to this board meeting, and the terms of reference are included under a later agenda item. So that's all from me, Heidi. I don't know if Richard or John have any further comments, or indeed Yelena or Rachel, who also attended the committee.
Anyone, John, Richard, anyone want to add any comments?
No further comments from me, Heidi. That was some of the conversation. I thought it was a very helpful one in terms of that alignment with KGH's audit committee, certainly from an agenda and workflow point of view. And as I said, I've tried to take the committees, both at KGH and NGH, through this is where I feel we need to get to from an audit point of view and where the issues are, and those played out at the NGH committee quite well, I think, actually.
Thank you. And I can confirm, David, that obviously I'm working closely with Richard, as are the other executives, on aligning the corporate risk register and board assurance framework work. So, and also to pick up your point, David, of executive ownership of outstanding actions, just to give the board assurance that BOLA is working very closely with our executives to make sure these are closed down in the immediate weeks ahead of the next audit committee. Anything from anybody else? No. So on that note, I have managed to finish 1 minute ahead of time, Chair. So I'll hand back to you.
Your watch is obviously a minute faster than mine. Well done. Thank you very much, Heidi. Operational plan submission. This is a very brief report on this, and what is a very complicated area, and where obviously lots of demands are being made both on the system and on us. But let's have this brief report in this session, and John will no doubt mention how non-execs in particular will be involved in making sure we're comfortable with what we're committing to before the submission goes in later in June, and more importantly, before our next board meeting. John.
Apologies, Chair, struggling to come off mute. I think Karen's going to kick off in terms of the summary, and then I'll provide a little more colour to that conversation, if that's okay.
Okay.
Thank you, John. Thank you, Chair. So yes, just to note, this paper presents the system, a summary of the system plan. And as we all know, we're not submitting individual plans by trust, but system plans this year. And the key points we wanted to just pick out is the delivery of the elective recovery as planned for, as is continued delivery of cancer performance and achievement of our cancer performance and elimination of our long wait. So building on the good work that we've done so far is anticipated for the remainder of this year. What we did want to focus on, the plan includes a very brief summary of the workforce movements, but the real focus we wanted to pick up today was the requirements for a new plan submission on the 20th of June, and what this means in terms of particularly around that balance between our finance delivery and our performance. So I'll hand over to John, who's going to pick up on that, because I think that's key for today.
Thanks for that, Karen. So I'll take the point to be brief, Chair. So we submitted a plan as a system. That was a deficit plan that was consistent with every other plan that was submitted nationally. All systems submitted deficit plan. We are working through with system colleagues and national colleagues on how to work through some of the challenges that presents. Colleagues on the call will recognise, because they read the paper, the major challenges we have in terms of pressures for inflation and other things. There has been a proposed solution to that nationally on how additional funds will flow, and we need to work through, as I said, internally and across the system on what that means for us. Simon has articulated the wider challenge, which is essentially the expectation that we go back to pre-pandemic levels of productivity and output, and therefore by default workforce levels. And that is going to prove extremely challenging, both internally and across the system. We've had a number of very kind of direct but helpful and useful collaborative conversations with system partners on how we will work through that. There is a plan, a detailed plan on the areas that we will focus on that we didn't spend as much attention on in terms of the plan that we previously submitted at the end of April. You'll be aware that we spent the vast majority of our time focusing on being able to meet the 104% of 1920 output for elective care. And we are going to spend a bit more time over the coming weeks working through implications for ED and urgent care, notwithstanding the challenges and issues that have been raised already during this meeting. As you've already said, the plan is to take certainly our non-exec colleagues through a briefing on where we've got to on that in early June. I think the date is the 10th, but that may be wrong. And we will do so. We will then have a chance to have those conversations about the relative ask, challenge and assumptions, both internally at a system level, before it goes on to a review across the ICB before final submission on the 20th of June. So plan in place to work through those big moving parts. Clearly a very challenging ask on us, both as a system and as a hospital. We need to step through that work in the coming weeks, and we have a plan to do so, but it is going to be very challenging.
Yes, thank you, John. Just to reassure non-exec colleagues that on their away day, we're dedicating a very large part of that session to going through this in great detail, looking at any plans for development, very critically against where they require new funding, in particular against the requirement to break even. Everybody knows that there's been 2 years of, on the one hand, great difficulty with the COVID pandemic, but on the other hand, a rather different approach to money and financial planning during that period. So now we're coming back to what may appear to be harsh reality, but it's in practice just a normal state of affairs. And we have to look extremely critically at what we might wish to do to protect our services and to enhance our support for those services. In any event, the reassurance to the non-exec directors is that there will be a very detailed bit of time given over to that at the away date on the 10th, recognising that the system board will no doubt decide exactly how it wants to make this submission at its meeting prior to the 20th. Elena.
Thank you, Chair. My question is related to the workforce and the planned increases which presented in this pack. You know that I start going and visiting the hospital, so I need your help, executive colleagues. If somebody asks me how come the workforce of our hospital on last 2 years horizon increased by more than 700 full-time equivalents, how come the agency spend has also increased by 6-7 million on the last 2 years period, and we're still thinking of investing more in the workforce, however delivering which looks to the public just small increase, 104% of weighted average activities. So what should I reply to this question? Thank you.
Let's just give people a moment to think about that and go to Denise, but we will get you an answer to that. And clearly that's not a sustainable position. And the answer may well involve the word COVID fat, but nevertheless, it isn't a sustainable position. Denise.
Yes, thanks, Chair. I just wanted to ask, and I know, John, we did touch on this at committee yesterday, but the focus is on the sort of pre-pandemic levels of delivery in terms of output, workforce numbers. Do we yet have, can we yet kind of quantify that in terms of what that means for us? I know the information will be there, but at this stage, do we have any indication of what that looks like and how big that gap is for us? Thank you.
Yeah, I mean, I can certainly answer that we know exactly what our 2019-20 outcome was in terms of activity and what 104% of that looks like. But John can no doubt answer in greater detail. John and then Rachel.
Thank you, Chair. So if I pick up kind of Elena's question first. So as was presented to the board, I think a number of times now, the national position is that the workforce has grown. And by circa kind of 10% over the 2 years during the pandemic. So our workforce has, NGH has grown pretty much in line with that. The numbers that were presented to Finance Performance Committee yesterday said that our workforce has grown by circa 8 to 9%. And in whole time terms, just shy of 500 whole times. So those are numbers that colleagues should be aware of. So our growth, I think the important thing to note is certainly at NGH, the growth in workforce is not disproportionate to what's happened elsewhere. However, the challenge on us and the challenge that's been asked of us is the same that's been asked of everyone else, which is the level of additional staffing that has been required to respond to the pandemic, and not just the pandemic, actually, the significant challenges that we have been managing over the winter period just gone. The expectation is that certainly from a planning point of view, we assume that those challenges do not impede us as we move forward into the new financial year. We clearly have to work through the detail of why those costs were added in, why those people were added in, and we're going through those detailed conversations. We've already had a number of them, but we continue to have those detailed conversations as we kind of close out this next iteration of planning. But and a large chunk of them are we have had patients on designated pathways, and by splitting out our rotas and our wards between certain pathways, red, green and amber, previously before new IP infection prevention control guidance came in, means that our workforce is less efficient and productive than it previously was because of those care models. And that's something that we have, that has been imposed on us to a large degree. We now need to work through what we're able to do coming out the back end of that, to go back to something that looked like where we were pre those changes. I will also say that I think we've got further work to do around our temporary staffing and management of. I am expecting, and indeed have been told, that there will be a national refocus on the use of temporary staffing. Colleagues that have been around for a while will know that there were and indeed are agency caps for spend. I've been told categorically that those will be rolled out to cover bank staffing as well. So we will be being managed as a hospital against some targets yet to be confirmed. And therefore we need to do some work, one, to best understand how we are where we are and what we're going to do about it. That's clearly the ask for the coming weeks, and clearly the ask that we'll need to present and work through, as the chair has said, on the 10th. So I don't have a simple answer on why they've been added. The answer is wide and various, but we are not out of step with the rest of the country. But the ask nationally is those reins get pulled in, and those reins being pulled in will come through, one, as part of our reduction in funding allocation, which has happened and has been communicated to us and is part of the reason that we submitted a deficit plan. But secondly, those further controls around bank and agency, both rates and caps.
Thank you. It's a good question, as usual, because we have struggled over a long time. The answer is undoubtedly complicated. We're not going to answer it in the next few minutes, but there's plenty of room for that to be explored deeply in the away day on the 10th of June, because we have to thoroughly understand this. And I think it is also just worth reiterating that in a publicly funded service, it's not at all unreasonable to expect us to live within the budget allocated by Parliament. So that becomes the expectation, which has been obviously easier in the last 2 years after various comments from the Chancellor along the lines of money no object. That time cannot continue and clearly isn't. Rachel, and then Mark, and then Matt.
Thanks. We had a long discussion about this at Finance and Performance yesterday, and a couple of points were made, which were interesting. One is, so obviously for the next submission, we've got to go back to the activity levels pre-pandemic and use them as a baseline. But actually we did discuss the question of, well, during that year, which I think was 1920, were those resources, the people resources and the number of them, was that fit for purpose then, or are we just going back to something that actually possibly wasn't working that well? So that's one of the questions that I think we need to answer. And the next one is, what have our staff and patients actually got out of having more staff over the last couple of years? Is it that there are huge benefits in terms of productivity in places? So I think this is, as you say, Alan, more complicated and is going to need an awful lot of work. The other one I want to just pick up on was this benefits tracking that I know I keep saying, but we will inevitably be under huge financial pressure, and it will mean that we will have to land these efficiency programs. And unless we very quickly have an idea of the progress, are they hitting the milestones? Are we getting the required improvements in productivity, reductions in cost out of them? I go back to the old adage, if you don't track it, you can't manage it. So that is something I think we need to be very quickly have in our sights. And the other one was the request to have a session on ICANN, given how important that is to landing our financial position this year. So I think Becky has taken that away to put together a progress review and update the non-execs on progress there. Thank you.
Okay, I know this is a big topic, but I am very conscious of time, and we will be talking about it from a non-exec perspective, at least on 10th. I'm sure the exec groups will be talking about it a lot. So briefly, please, guys, Mark, Matt, Heidi, then Simon.
Thank you, Chairman. I think I will be as brief as I can, because obviously we could go on about this for a hell of a long time, as described. I think the one thing, Elena, in terms of your question too, though, is that I think staff equally, because we noticed on the staff survey, wouldn't say they recognise the investment of the 740 whole-time equivalents that we've put into the organisation over the past 3 years. And I think, how do we square that circle? Because that's a really difficult position too. So in the increases in posts that we put in over this period of time, the deterioration in the staff survey has been we don't have enough people to fulfil the work that we need to undertake as a hospital. And I think that's a really difficult balance for us to strike. All of the other points that I would have made have pretty much been said earlier in early responses.
Thank you, Matt. Matt's disappeared on me.
No, sorry, also be succinct and not cover what's already been said. But clearly, to answer your specific question about how do you square off the increase in staffing with the also increased spend on agency, a lot of it has been driven by short notice, unpredictable or absent, which can only be covered through agency most of the time. To Rachel's point around how do we know our baseline was right? Well, we did a fairly detailed piece of work leading into the pandemic that certainly in medical staffing suggested we were 12% shy, so a 10% uplift might take us roughly where we ought to be, one might surmise. And finally, to John's point around the controls for agency, in my experience, you can layer on as many controls as you like, but the effective way of reducing agency spend is to get your establishment where it needs to be in the first place. Very helpfully, a lot of the work around the University Hospitals brand and some of the better promotional materials that we've been using in our advertisements and our offer for in a competitive marketplace has seen a notable uptick in applications, particularly for senior medical posts. Thank you.
Thanks. Heidi, then Simon.
Thanks. So 2 points really. So one, I think, Elena, it's a really good question that people will inevitably be asking. And I think it's a mix of Matt describing actually the benchmark of where we were at the beginning. A lot of this increases our acute medical unit increased spend, and that's a lot of agency, which I think is important to note to the board. That won't be recovered within year because there aren't enough acute medics out there. So our teams are working really hard to look at what the future model of acute medicine will look like and what that means in the wider context of the system conversation we're having. That's the second point I wanted to make. There has been, during the pandemic, as we know, a change in activity of people coming to every hospital, and Palmer referred to it earlier, the number of increased attendances. So we are seeing people that we wouldn't normally see. So some of this is dependent on the collective system working, which is a real opportunity for ICSs, but some of the increased spend, which no doubt Simon will come into cover, is a symptom of the change in behaviours and capacity in other areas not being available. So some of the ICANN work, some of the system working, and the urgent treatment centre I referred to earlier is crucial to us moving some of this forward as well.
Thank you, Simon.
And to conclude, the system context will need to be played into this discussion, because Dale challenged the system at the QSRM on you still have higher than other people numbers of super stranded and stranded. Alan has said consistently, what price for us, to quote you back to yourself, what price for us if we were able to imagine a hospital that didn't have that number of super stranded patients in it. So Elena, directly, there is a component that the hospital, both hospitals have had to price in the provision of, if you like, holding patients who could be cared for somewhere else, and that capacity has never existed. And we are now coming back to your point about pre-pandemic levels of activity and service. We're coming back to that too for our colleagues. And if this is going to be different, that's got to be different too. So I will leave you with the question, what is it worth to us if we had that opportunity, that capacity outside the hospital?
Thank you, everybody. Clearly, every time we go through a planning round, it's a balance between people, patients, and money. the last 2 years, that balance has actually been only between two things: people and patients, and the money issue was not a particularly relevant one. The money side of the triangle is now being re-established, and I'm sure as a taxpayer, people would quite like to hear that, but it has other consequences. So there is no doubt that the parliamentary vote is sacrosanct in the health service at a national level. So there's all sorts of debates to be held, both with our regional director, with our regional executive, about how best to handle that national vote, but there's also all sorts of debates to be held locally about what we do with our colleagues, including local government, to try and ensure that we get to do what we do, as opposed to look after people who shouldn't be with us. Those are all very valid points, but I don't want people to go away thinking that the money limit is now something that we can happily sort of debate or think doesn't apply to us. So those are going to be serious. Those are going to be serious debates, and we have to hold a really good, deep discussion on what we think our priorities are to deliver the right kind of patient care with the right kind of staff between now and the 20th, effectively, and that's not very long. Okay, thank you very much, everybody. We're now having gone on about timekeeping to Heidi. We're now a little bit late, so 11:20 back, please, after a short break. Thank you. Okay, 11:20, everybody should be back. Thank you very much. The group clinical strategy. We ought to remind ourselves that in the group, when the group clinical strategy was discussed around Christmas time and approved by the board, we were very conscious that this was our version of what we wanted, the version our clinicians and other groups had decided was the right thing to do. And we always made the point that we were then going to take that out into other parts of the system, the county, the local government, and other areas of our patients, our governors, our staff, wider staff groups, and ask them what they thought of it. So now we've done that pretty comprehensively, I hope, or I know for the most part, with a couple of small difficulties with meetings being cancelled, which Polly will probably allude to at some point. But otherwise, we've gone through quite a good process, and you can see as we go through this, talk about what people have said to us, talk around the "you said, we did" concept, and how we've ended up with a document which we believe reflects both our wishes but the views of everybody else in the system. And we're in a position then to ratify it and step forward with, okay, what does that mean? What are we going to do in the coming year to deliver this clinical strategy? It's always worth reminding ourselves that the reason we wanted to be a group was not to merge all sorts of things, but rather to make our clinical services better and more robust, more focused, and to think about how you might treat 800,000 people, not two groups of 400,000 people. And that's what the clinical strategy is largely about. Excellently produced, excellently consulted upon, and here's the answer. Okay, I presume I'm handing over to Matt at this point.
Thank you, Chair. Yes, I presume so too. I'm delighted to be joined by Polly Grimmett, the Group Director of Strategy, and also Rabia Imtiaz, my counterpart at Kettering General Hospital. And I'm going to take the liberty of sharing some slides just to demonstrate that I've got with the 21st century. Can everybody see that, please?
Yes, you're on.
Fantastic, thank you. So as Alan has alluded to, colleagues will remember that in November last year, following a 7-month development process with literally hundreds of our clinical leaders, as well as colleagues from strategy, we were able to present and agree at both of our trust boards the clinical ambition towards the clinical strategy, and then thence the consultation process. And the purpose of today's presentation and discussion is to update on the progress of said consultation and seek the endorsement of the board for next steps. So remembering only very briefly the case for change from the perspective of the hospitals of the group is that we have a population that is growing and aging even more rapidly than the national average, presenting its challenges in order to maintain high quality timely healthcare, along with a national picture of some critical shortages in workforce for some clinical groups. That recruiting and training staff is something where we have to make ourselves very attractive for people, and our patients need us to be offering joined up care. But of course, perhaps the best lens through which we would wish to examine the need for our collaboration and our joined up clinical strategy across the hospitals of UHN comes through the lens and the voices of our patients. And colleagues may remember the powerful and emotional story that Nikki told of her own cancer diagnosis and the anxieties through the waiting stage that she articulated beautifully during diagnosis, and then the emotional roller coaster of successive treatments through surgery and then chemotherapy. And she, although very, very kind about the clinical teams who looked after her, would truly have valued a more seamless and joined up approach to her care through that very difficult time in her life. Colleagues may also remember Keith, a fit retired firefighter who suffered out of the blue, completely unexpected heart attack, and described very clearly and vividly the ways in which we could perhaps have offered him better and more joined up care. Again, a bit of a theme emerging. And he described how he wrote a message on his phone for his wife in one night because he was frightened he was going to die. And so we have cancer and heart disease, two of the major burdens of disease and two of the biggest killers in our society and here in our county also. We've got real lived experiences of two of the patients, and clearly something where we would wish to offer the very best that we could across our hospitals. And then we've also heard from Bernadette, who is treated by one of our Vanguard collaboration services in ear, nose and throat. And she described the experience of effectively being ping-ponged between our hospital and Kettering General Hospital, because we hadn't managed to set up our services in a way that was centred around providing a high quality and good experience for our patients, rather more around the historical boundaries of our two hospitals. So for all of those reasons, those we would very much wish, those were more than enough reason for us to really want to get it right for Nikki, for Keith and for Bernadette, and work our collective and collaborative endeavours across the University Hospitals of Northamptonshire. And I'd like to hand over to Holly, if I may.
Thank you, Matt. So I'm going to take you through a few slides that just set out, as you mentioned, Chair, the wide breadth of engagement that we have been undertaking over the course of the last few months since we signed off the ambition document. I think it was November boards. So this slide is a reminder of actually the engagement we did as we developed that ambition document. So there certainly wasn't a few people in a dark room. This is absolutely our clinical staff who came forward, took part in all of the engagement. We had one of the most popular staff surveys of all time, nearly 500 responses across the group came in for that, of which over 80% fully supported clinical collaboration between the two sites as a way of improving care that we deliver for patients and improving recruitment and retention and staff development. So it was, staff were overwhelmingly supportive of that, which led us into producing the ambition document. And to do that, we had a couple of conferences, a couple of face-to-face conferences, and a huge amount of pillar work. So our thanks to the clinical teams for that. Now, since November board, as you quite rightly mentioned, we wanted to go out and speak to our wider partners and speak to our staff about the document, about what they thought about it, to make sure that we could develop it further and mature it further into a really well-rounded document. And we've been doing that. We actually decided to take an extension to the initial period we'd planned to do. And that's because everybody was very busy with winter, and we wanted to make it a really meaningful engagement where our staff could take the time to come and interact with the document and feedback their views. We didn't want to rush it, considering everybody was very busy with the pandemic and winter. So that's why we decided to take a few months extra, and we're very glad we did. So next slide, please, Matt. So in terms of the breadth of the people we've spoken to, we've run numerous, perhaps 20 plus different staff engagement events chaired by the medical directors and by Simon. Over 600 of our staff have been at those, and you can see there, I won't go through the wide breadth of different types of staff and different grades of staff that have taken part in that. And we have kept a really detailed spreadsheet. Every single line of feedback, either given verbally or through our survey and through the link that's gone out to the public, has been kept, and we have a central record of all of those items of feedback. We've also been out to all of our ICS partners. You can see there the list. We haven't as yet managed to get to our health and wellbeing boards. Unfortunately, those meetings got cancelled in May, but we are on the agenda for June and July respectively across the North and the West, to go to the health and wellbeing boards, to take our document and explain the wide range of engagement that we've done with our staff, with our partners, and of course with our public and our patients. So in terms of our public and our patients, we've held some public events, 4 public events that we widely publicised in the press and in our social media. And we've also had dedicated sessions, particularly around our centres of excellence and some of the services, where patient users have been coming along and feeding back what their views are and how they felt. So In terms of some of the key themes, although we've got over 500 different lines of feedback, they have coalesced around these kind of broad themes here. And I'm just going to pick out in the following couple of slides some of the key things that people were saying on the more popular items, so the centres of excellence, integration, and working together as a single team. So in terms of centres of excellence, we've got 2 that we had in our ambition document, cardiology and cancer, and there was overwhelming enthusiasm from everybody about the principle of what a centre of excellence is, that it's a really strong way of recruiting in some high-level staff into those areas, of developing our staff in terms of training and development, and improving our services to patients. So lots of enthusiasm about that. I think some of the areas of concern, and this came out actually initially in the first week or 2 of our engagement, which was really helpful because we've managed to address it since, is a little bit of a confusion about some of our terminology in the ambition document about our centres of excellence. So we've now been really clear. It's one of the key differences that you will see between the ambition document and the strategy that's we're talking about today, being really clear that the centres of excellence are for all of Northamptonshire. They might be led by one hospital or another, but they are for all patients in the county, they are for all staff in the county. And we've been much clearer in the document about that, and also about the fact we've delighted that we have a robot at Northampton Hospital to support our Cancer Centre of Excellence. But again, that is for all patients in the county and for all staff, and our surgeons across the county can go and use that robot and be trained up in it. So that was really helpful. We managed to address that in our communication going forward, and in a clinical senate that we had last week with a lot of our consultants and medical staff, they were very happy that our document now does state that much more clearly. In terms of a single team, again, as I've already said, people, all of our staff, very keen and can see the benefits of working together as single teams, but not unexpectedly, some concern that we might suddenly start to change where people, or ask people to work on different sites or change service provision. Again, so we've taken the opportunity to be a lot clearer in the document about how we will approach those kind of things. And that is that if it's in the best interests for patients to change our service provision, and we think it is, and that would absolutely have to be at the direction of our clinical staff. If they feel they can improve care for patients by either delivering services on one site or another, or indeed into community, then we will assess that case for change very carefully. We will do a lot wider engagement with our patients and with our staff around those ideas much earlier and in much more detail than this strategy document sets out. But we've explained that in a lot more detail, and that we will engage with staff going forward and with patients going forward. So this engagement doesn't stop here, and I'll talk about that in a moment. Thank you. Integration with community, and of course our plans around working at ICS and with our partners really is a massive enabler for us to change and really accelerate the way we're integrating our services and our patient pathways into community settings and with community and primary care providers. Lots of enthusiasm from our staff about that, and they really do see the benefits and the opportunities that the ICS and moving into the ICS can give them to delivering some of the things that they've wanted to deliver for a long time. Integrated heart failure service and respiratory services are 2 key ones that have been coming out, children's and young people another. So lots of support as well for us to continue to develop our plans across the ICS for community diagnostic hubs, and where possible moving activity where patients currently have to come into an acute hospital site for their diagnostics, moving that into community settings so it's much more convenient for our patients. One of the areas, however, where our ambition document, it was pointed out was quite quiet, it was on mental health, actually. So our ambition document initially did mention mental health, but only insofar as the mental health collaborative across the ICS. We were a little bit quiet, actually, as to how we're supporting the mental health and well-being of our patients when they need acute care and they're in our acute facilities. So we've strengthened that a lot in the document as a section on its own, but also as a common thread that goes throughout all of our strategy document now, is how we're supporting our mental health of our patients. Thank you, Matt. We've got a new section in the document on our pledges to be net zero carbon and how we want to improve our carbon footprint, both through some big things like our energy centres that both sites are going to be investing in this year, but also how we're going to improve our transformation of our pathways in terms of digital, so enabling patients where possible not to have to travel into an acute hospital site, so reducing their carbon footprint, and a whole variety of other measures. So there's now a dedicated section in our strategy document that sets out some of those ambitions. I don't need to talk about this because the overwhelming positivity around our academic strategy and our university status. So we have put more information in the document about that because our clinicians wanted to see that strengthened in the document. In terms of some of the other areas, I think the key thing that came out, and people were asking questions, not so much concerns, but just inquiring more about how are we going to deliver this. We all agree that it's the best thing to be doing, but to deliver it, we need the resource to deliver it. We need the digital platforms to enable us to collaborate across the sites, and we need a fit and functioning estate to be able for us to collaborate properly and improve our care for patients. So we have added in more detail in the strategy document about our digital strategy and our estate strategy and how we're going to be working on those over the next 6 months alongside delivering this strategy document. Thank you, Matt. I think I'm handing back to Matt now, who'll take you through a reminder of the key things that are in it. But as I say, the other key difference in the document is we have started to add more detail in about our centres of excellence and about our pledge for protected elective capacity. So you will notice that there is a next level of detail on some of that. We had a very positive launch event for our cardiology centre of excellence recently, and we have one planned for our cancer centre of excellence on the 8th of July. But this document is an iterative document. We will be adding in lots more detail as we go. And as I mentioned earlier, the engagement will continue both with our staff and with our patients and with our partners as we start to work up those strategies in more detail. Over to you, Matt.
Thank you ever so much, Polly. And I will invite Rabia to share her brief reflections also in a moment. But as you quite rightly say, the next step is really to set out where that extensive process of engagement has got us to with our strategy. I think it will probably be fair to summarise that the feedback has been enormously helpful in letting us know how we can better articulate and refine the story that we are sharing with colleagues, the way in which we are communicating. And I think it would also be fair to say that they're, broadly speaking, the 4 key domains of the strategy that we would wish to be driving forward remain better articulated but largely unchanged in substance. So we remain really keen as one of the 4 key domains to work with partners to prevent ill health and reduce hospitalisation, and as part of that to work with partners to reduce health inequalities. And indeed, of course, strategies are living entities, not documents that should just be collecting dust on shelves somewhere. So we heard in the patient story at the beginning of board today that the work that the IRIS Continuity of Care Midwifery team have done, and how helpful that was for a new mother, a new family, and in an area where we know we have work to do in terms of reducing health inequalities. The second key domain is to develop centres of excellence, and we have just referenced the powerful stories from Nikki, a cancer patient, and Keith, a heart attack survivor. Excuse me. And if anyone could embody better the cases for the centres of excellence led by one or other of our hospitals and delivered across both. So in the case of cardiology, that will be led from Kettering but delivered across both of our hospitals of UHN. In the case of cancer, we will be leading that here at Northampton General Hospital, but on behalf of both hospitals and of course on behalf of the population that we serve. And Again, it's a living document. We've already made some substantial commitments. For instance, here at the Cancer Centre of Excellence, we have already started operating with the assistance of a robot, such that patients with prostate cancer, patients with rectal cancer, already 15 in total, have had their radical cancer surgery here in the county without having to travel further and without having to wait many months for their surgery. So with better outcomes and better experience for patients. We are absolutely committed to ring fencing elective capacity. We've already talked in the planning session item of this agenda around the importance of recovering the backlogs of elective work created through the COVID pandemic. And if we are to maintain our excellent position benchmark nationally and continue to improve upon it with the commitment that we have set out in our plans, then we are going to have to find a way and more importantly, the courage to ring fence elective activity as we reduce our waiting lists. And we will be having shared waiting lists across the county, which will improve access and reduce health inequalities. And finally, but by no means least, and probably closest to my own heart, we will continue to build on our university hospital status and become known regionally and indeed ultimately nationally and internationally as a hub for innovation and research. We have taken to market the innovative ideas of our own staff here in pharmacy at Northampton General Hospital, for instance. We have record recruitment of patients, offered access into research trials, offering them better care and also shaping the standard of care of the future. As has already been touched upon, we have been successful in our partnership bids with the University of Leicester and University of Hospitals of Leicester to join their clinical research facility and also their biomedical research centres. And as already mentioned briefly, almost every consultant of whom applying for jobs at our hospital, of whom we've seen a marked increase in number, have mentioned the university hospital status and how excited they are by it. So those remain the 4 key domains of the strategy we wish to drive forward. Polly has already touched largely on this slide, that over the next couple of months, it is having received the generosity of our colleagues in feeding back and really helping us to improve both the presentation and the content of our strategy document. We will do them the reciprocal courtesy of feeding back to them in how we have incorporated their feedback and the way in which they've helped us to shape it. We will continue to engage with the public and with our partners in the integrated care system of the county. And the formalities are important formalities of taking this strategy through to our health and wellbeing bodies and overview and scrutiny committees. And we have a plan for the next year of how we will take forward some of the key year one priorities for our strategy. But in order to allow time for a due discussion, we'll stop there, and perhaps if I could invite Rabia in to add any reflections, if that is okay, Chair, in the first instance.
Okay, Rabia.
Thank you, Matt, and thank you, Polly, for covering clinical strategy. I wouldn't repeat any of what you've said, but one of the things which I just wanted to highlight is that there are certainly enablers which have been identified and addressed in our clinical strategy, which are important for us to deliver it with regards to infrastructure around digital and estate, and the governance and leadership aspect of it is covered as well, and which is really, really important. What I really wanted to do, Chair, is just share 2 examples to say that how clinical strategy is already helping driving the the joint integrated care, actually not across the group, but across the whole county is one of the example I would like to share is we currently have challenges around therapists, both occupational physiotherapists as well. And what we've done is that as part of the system therapy group and committee, which is led by one of the catering therapists, we are developing a system-wide pool of therapists. And those therapists will be then used across not just the two trusts, but the primary care and NHFT as well. And the other more recent one is joining a system-wide, in fact, I think it's the multi-center trial for the research. So one of our most recently appointed associate professor has now is setting up a multi-center study across the whole system involving Northampton and Kettering General Hospital, primary care and NHFT, which would be looking at how best we can learn from case investigations into harms and errors. And I think that would be something really good, again, example of how integrated care can help patient care in the long run.
Okay, thank you. It's been a long journey. It's been a good piece of work. Comments, questions, or nods of approval? Elena, then Jill, please.
Thank you, Chair, and thank you to Matt, Rabbi, and everyone who was involved in shaping this clinical strategy. It's so impressive how many engagement sessions you had with colleagues, external stakeholders, and also us non-executive directors, dedicating your time even after 5-6 p.m. in the evening. Thanks a lot. Considering that the frontline colleagues are very exhausted fighting COVID during last two years, how would you assess the level of enthusiasm and energy in our clinical colleagues group to implement this strategy at pace?
Let's just hold that thought. Jill and then Rachel, please.
Thank you. Apart from also commending all the work on engagement, I've got two specific questions. Matt referenced inequalities, and indeed at the beginning of the board we had a presentation, did we not, which focused on a newish model of maternity care, which does look to reduce inequalities in clinical outcomes, supported by research. Where are we going with the clinical strategy to do that in other areas? There's a mention of it in relation to elective services, but not much else. And then secondly, I'm interested, as Elena has just referenced, in the implementation of the strategy and where we will oversee that. So Rachel mentioned earlier that the CPC would be looking at strategies, or has started to look at strategies from the through the lens of improving productivity and from a financial perspective. Will we also be looking at this from a clinical perspective in our group clinical quality committee? Thank you.
Okay, I'm sure Matt and others are holding on to these questions. Rachel and then David, and then we'll go to some answers.
Just a quick question on the back of Jill's question. Mine is around cancer and rehab following initial diagnosis and treatment. It's well documented now that the rehab and exercise in particular can reduce the chances of recurrence. So I was just wondering, given the focus on cancer, where we are going to pick that up. Thank you.
And David.
Yeah, my main question I think has been asked, but I think it's very encouraging to see all the engagement work that has been done, around staff, patients, and partners. But around patients, I do have a slight concern, but I did get reassurance from the last slide that we are going out to Health Watch, we are going out to Northamptonshire partners, because I think we're going to be able to see this from a very different lens. And I think some of the issues which are going to come up generally speaking, things such as travel, transport, etc., are going to be issues that we have to look at very, very carefully as we implement this strategy. So I'd be very interesting to hear in a future board meeting about the what happens from those engagement sessions.
Okay, a good range of questions. Matt, I presume.
Thank you. I'm more than happy to go those answers and bring Polly and Rabia in for their own reflections. So, in relation to Elaine's question around exhausted staff, what are their enthusiasm and energy levels for pressing with this at pace? I think the short answer to your question is they're pretty high. You may be even surprisingly high, but people are quite keen to do something else other than COVID, to be honest. The engagement with we've been really careful, as colleagues will remember, as we have developed the strategy, not to make it about sort of two DGHs clinging together for survival, but actually have really uplifting and positive advantages of coming together as university hospitals, putting new strings to our bow that make this a great place to be, a great place to work, a great place to deliver and to receive care. And I think people buy into that to a greater extent. So, for instance, I touched upon the surgical robot and the cancer patients who are getting more timely, more local care than they would have done previously. And not only have we got enthusiastic surgeons already, bearing in mind this robot arrived, I think, in the last week of February, and we've got 2 different specialties with different surgeons already operating on the robot. And we've got surgeons from both of our hospitals engaging with and on the training programs to use the robot as truly part of the UHN family. And so I think that, Elena, although it's a very reasonable concern, I think that the levels of enthusiasm and energy are actually pretty high. People are up for this. There will be inevitably the anxieties that we will address as we go through, and we are doing with an awful lot of small group meetings, one-to-one meetings. But getting clinicians enthused about doing better for patients is actually not that hard to sell when it comes to it. In relation to the inequalities, I mean, it's a really good question, Jill. So I suppose I would say a couple of things. First of all, I'd link it to David's question, where he used the example of travel and transport. Well, really interestingly, during the engagement, one of our colleagues, because transport and between sites for staff was something that came up again and again during the engagement, entirely legitimately, entirely reasonably. One of the solutions we were exploring with them is maybe getting a small fleet of electric buses, for shuttle buses. And one of the ideas that was brought up also by staff was that we could use those also to help patients not just move between our hospitals, but for us to reach out into some of our more deprived areas, for instance, remembering our postcodes with really high socioeconomic deprivation indices in our county. And the more high-level strategic answer to the inequalities question is, of course, that is probably primarily an ICS space, so an integrated care system space, with which we will continue to fully engage. So the system has produced its draft improving outcomes framework that has been endorsed by the Public Health Board of the county, and has yet to progress through the quality committees and the Integrated Care Board Shadows/NHCP board. And we will fully engage with our clinical teams, and our strategy teams will fully engage and make sure that we integrate, because our clinicians are really keen to engage in primary and secondary prevention and reducing health inequalities. But at the moment, we are not the rate limiting step in being able to further progress that agenda. Implementation and oversight, Jill, as you know, a group of execs and non-execs have discussed that quite recently. And we would absolutely agree that during the development and implementation phase, CPC is the right forum to make sure that we're on track, to support and to hold an account. And we've also sort of touched upon that we will need to agree a sign-off process for different bits as they are felt to be transitioning into business as usual. And at that point, any ongoing monitoring. To Rachel's earlier point, if you can't track it, you can't manage it. We'll have a handover process to the relevant committee in common, we suggest, but probably, as was implied, it might be helpful to bring back further details of that as they are worked up. Prehab for cancer is a really prehab and rehab actually for cancer, both of which make a difference to outcomes. You're absolutely right, Rachel. Is a space that already the ICS Cancer Transformation Board is doing some work on, and we are engaging with them as we start to work up our group cancer strategy, which is a more complex beast and therefore slightly behind the curve of the group cardiology strategy that has been mentioned earlier. But your points around prehab and rehab have been captured in the working groups that are starting to form, and is very much on the agenda. I'm not able to give you a more fully formed answer to that, Rachel, other than their commitment that it will be attended to. I think that largely covers off the questions as I understood them.
Okay.
Welcome, Polly and Robbie's reflections.
Okay, thank you very much, Matt, and others. As I say, it's a good piece of work. It's work in progress. We still have to keep saying, okay, what exactly are we going to do this year? And in due course, I'll no doubt come back and say, that's fine, what are you going to do next year? And we need to keep up the momentum on this, both within the hospital and outside the hospital. So good piece of work. Thank you very much, everybody. Conscious of time again, my fault this time. Staff survey response. Mark, please.
Thank you, Alan. So taking the lead on that, I will take the paper as read and won't go through that in huge detail. That to be said, that it doesn't underline any sort of issue with the significance of this piece of work. We know this is a really challenged position for us. The National Staff Survey results were released at the end of March, and there's very much a lot of work that we need to do around them. I think it's fair to say that we found them disappointing in terms of where we find ourselves in the staff survey. They have been shared, so the results have been shared across the hospital in terms of making colleagues aware as to where we have issues, and therefore also asking, as you quite rightly expect, as Heidi referenced earlier, what we can do about them. So let's listen, let's hear, let's understand, and let's explore what we can do differently and what steps we can take to amend them, which I know we spent a significant portion of our time discussing on the 29th of April in our board development session, and we'll again undertake that on the 30th of June. You know, this is something that we're all committed to. As Simon also referenced, we've got a pulse survey in place now, which is also helping us. It's just referenced in the paper too, that enables us to respond more proactively to things that are raised. So rather than waiting for an annual staff survey, we have the quarterly survey. And again, whilst Denise referenced earlier, the results are not necessarily moving as we would like them to into a more positive position. What it does give us is huge intelligence as to what actions we can take in order to support the workforce and to make some of those changes. And we are seeing increased participation rates. You know, I remember starting off in September saying how fantastic it was that we received 17% completion rate, and we're now into 24 across the hospital, which is really, really positive, and we must continue to act and respond to that feedback that we're given and was articulated earlier. However, we know this is going to take a huge cultural improvement piece of work, as we discussed on the 29th of April and the 30th of June, or we will discuss on the 30th of June, and it's going to take a huge coordinated effort to complete this. That being said, there are some work that we can undertake as well in terms of leadership and management and reward and recognition. So as an example of that, having a program in place for how we develop our leaders and managers, that will be coming back at the end of June at 2. And from a reward and recognition perspective, we've done quite a lot of work on looking at this in the hospital, and also more widely with things such as our long service awards that we will be able to bring back on stream, and current plans are being formulated to have that event on the 5th of July. I mention it here because obviously the next time we meet in public will be the end of July, and I hope to be sharing the celebrations that we're able to undertake on the 5th. I'm happy to take any questions and comments on the staff survey. I'm mindful that it's been something that we've discussed and debated a lot over the last couple of weeks. Alan, you're just on mute there.
Thank you very much, Mark. You have indeed, as you rightly point out, spent a lot of time, quite rightly, on this, spending the entire development session in last month. on it and developing clear plans to address it. Denise, please.
Yes, thanks, Chair. Just a very brief comment to, I think, reinforce what Mark was saying, that we have discussed this a lot. The work that we do moving forward is going to be the key here. And I think having the pulse surveys more frequently is proving to be really useful in terms of seeing how opinions are shifting or not, and really focusing in on the things that matter to people. So this whole aspect of "you said we did," and however you sort of term that, is really important. I think that from conversations with staff, people are looking now to see what, we keep telling you what we think, what are you doing about it? So lots and lots of activity on that, and the work that we lead in terms of the culture improvement is really important. Thank you.
Yes, Denise, absolutely right. There has been, it's fair to say, a bit of a history of a lot of talking about this and not a huge amount of success in addressing some of the issues raised by staff. Some of them are, of course, a little bit new. It's inevitably the case, and we need to address those, but some of them are pretty long-standing, so the record for addressing them is not great, and we really do need to respond very positively to this. Last word to Heidi.
Thanks, Chair. So just to follow on from Denise, that closing the loop point is why we've launched the branding of connecting with our teams under Connect, Explore, Improve at NGH, to make sure we keep this real focus on being transparent about what they're connecting with us about. That might be something that's really good that needs to share learning, but it might be something that needs improving, then exploring it together and driving that ownership of improvement together so that they can see that there's a commitment to closing the loop. So that's going through all of our conversations, our safety huddles, and the way we're connecting with teams when we're going out to understand. So we've adapted the framework to make sure we're building in that exploration and closing the loop.
Okay, excellent. Thank you very much. Good responses. We do take this extremely seriously, and as I say, I recognise, and I know the Trust leadership recognises that our record in responding to some of the issues raised in track surveys over a number of years, going back quite a long time, has not been terrific, and we do need to, as Heidi says, close the loop on this and very clearly set about listening, very listening constantly and with a method which gives us a way of delivering a response to those things. I'm sure Denise and her People Committee will consider to continue to overview that. So thank you very much for that. Right, Trust response to the Ockenden reports. As we mentioned right at the start, our Director of Nursing is not with us today. But we're in the extremely fortunate place of having a hospital chief exec who also happened in a distant past being a midwife, and so is more than competent on talking about this. It is an issue that was mentioned in our patient survey about conversations about fears following on the events in other hospitals, Shrewsbury and Telford, but others as well, with maternity problems. We have previously, in response to Ockenden phase 1, asked the question, how does the board know that our maternity services are safe? And I emphasize the word know, as opposed to hope, expect, believe, or etc. And we answered that question several times in public board meetings. However, Ockenden raises a number of new measures, a number of new requirements, which have to be met in order to satisfy our regulators and indeed ourselves about the quality and safety of our maternity services. And in this report, you can see a detailed analysis of where we stand against existing metrics and the new Ockenden metrics. So, Heidi, over to you, please.
Thanks, Chair. I'll also bring in Jill as our NED, who's heavily involved in this work after me. So I'm going to give you an overview. Essentially, I think the first really important point to acknowledge is the Ockenden report itself and how incredibly sad and hard that is to read for both our teams and the public. Obviously, thinking about, as you said, Alan, the impact on them themselves. So I think it's really important to say we welcome it. it gives us a real opportunity, not only in our maternity service, but as a hospital actually, to really take some of the learning hospital-wide in terms of listening to the public and really learning from a number of events. So I think the important point to note is we really welcome it and committed to using it as an opportunity to drive improvement. The second point I'd like to make is obviously we acknowledge and have discussed in the board before, we do have some challenges in our maternity unit in terms of staffing, leadership capacity and culture. Obviously we've already started to address some of those, and delighted to say that our new head of midwifery, Claire Flower, has now started with us and already making a really key difference to the service. Our OD piece of work, Building Tomorrow Together, is well underway, and that is starting to really make a difference that teams have an opportunity to speak up in a really proactive way. Our Freedom to Speak Up Guardian is working closely to make sure people feel safe to speak up. And we're also working really closely with Janet Driver, our regional chief midwife, on the work and the risk that we do have in our current maternity unit. As you'll see from the report, we welcomed the regional team in and asked them to come and do a review against the first Ockenden report. And you'll see the outcome of that in the papers, so I'll take that as read. But there were a number of points of celebration. One of them actually was to celebrate the involvement of Anna Jill and how involved and committed she is to working with us to drive improvement. Others were, they acknowledged the cultural piece of work we're doing, the really positive relationships between obstetricians and midwives, and Maternity Voices partnership being a real strength in terms of hearing women's voices. There were a number of issues for us to improve. None of them were things that we didn't know. So we are obviously already have those in train. Some of them were about our digital solution, which Andy may want to come in on. Some of it is about strengthening our governance and our SI process, which is well underway. And as you know, we have a weekly oversight of that from our executive team at the moment. So Ockenden 2, we're currently doing a really robust assessment against this and gap analysis to make sure, and as a number of trusts are, the extent of there's 15 immediate essential actions, but there are 92 sub-actions. So we're working through this really comprehensively. And I'd like to acknowledge the real commitment from our clinical lead, Sue Lloyd, in this work, along with everybody else in the team, the divisional team. And obviously Debbie, our Director of Nursing. So we're working with the region and have linked with Janet Driver on a number of those actions because some of them are being discussed at on the national platform in terms of what those mean for units in reality. So it's a very constant collaborative conversation with the region. They're the main points I really wanted to pull out of the report given the time, Chair, but obviously I'm assuming I'll probably have some questions.
Yes, I can't imagine that Jill doesn't want to comment on it, but we'll go to Andy first and then Jill.
Yeah, thanks. I was just going to build on what Heidi said around the digital solution. So clearly the need for shared records across the county was raised in the report. So couple of things that are on track. So as we speak, we're testing the sort of access between the two systems using what's called virtual desktop integration. So that allows people to view each other's system. So that will give us a kind of interim help. And then in the meantime, we'll be workshopping both with our existing suppliers, but also looking at what other things are available to get to the right solution. So it's important to note that across the country, this has been lots of people are looking at this, and so it's very much lots of teams across the country in the digital teams are looking at what the best solution is. So there's stuff that we can draw upon as we develop that.
Thank you, Jill.
Thank you. Just wanted to add to what Heidi's already said. In terms of the initial Ockenden report, interestingly, we've had quite a lot of challenges from the region where we say we're not fully compliant yet. We're on track with our actions. We have recruited 3 consultants to help us fulfill the expectations, but they're not actually in the hospital yet, so we don't consider that those actions are yet closed. But the region said, well, you could actually mark yourself green. So it's been quite an interesting debate, but we don't want to turn ourselves green until we have completed fully all the actions. So the board, and particularly the Quality Committee, might have seen some red, amber, green in relation to those 5 outstanding actions, and that's why there's been this debate. But they are 100% on track, which is great. Really support the time that we're taking to review the final Ockenden report. It's extremely helpful to have a new head of midwifery at this point with a fresh pair of eyes, because she will be able to ask questions, and indeed needs to ask the questions about what's already in place and why is this happening, etc. So that, I think that will really add to our review of the final Ockenden report. And I think it's important we don't rush it, that we do it properly. We've referenced a few times this morning our workforce challenges, and that's importantly referenced in the final Ockenden report. The fact that for example, when staff are off on maternity leave, that's not counted entirely into establishments of maternity units, and it should be. We're ahead of the game on that in terms of our people, leaders, and our finance team thinking about how that could be changed going forward. So that's really helpful, because we don't have a huge number of vacancies in maternity services, but what we do have is a large number of our staff unavailable for various reasons, including maternity leave, and that's what's giving us the challenge. So look forward to the development of quite an innovative workforce plan, which looks at doing things really differently and creatively. Both Heidi and I have had the privilege of working nationally with maternity units, and no one unit has got this right. So I think we've got an opportunity to really do something different and special. So I don't think there's anything else I wanted to say at this point, but except that we continue to focus on the safety of the services, hold regular extraordinary meetings with maternity and neonatal colleagues, looking at the data available to us to make sure that we're maintaining a safe service while we're reviewing the Ockenden report. Thank you.
Thank you very much. Any other comments at all before I go to Simon? Yes, Denise.
Thank you, Chair. Just briefly again to sort of reflecting on what Jill said, and I know that an enormous amount of work has gone into this. So thank you very much to all members of the team. Accepting, and it was in the report as well, that we can't rush this. We need to do it properly. We need to put the time into it. But do we have any indication of timescales here for Ockenden 2 in terms of I think that there was another self-assessment that Heidi referred to that should be completed soon. Have we got any indication of how long this work is going to take? Thank you.
Heidi, perhaps you could answer the specific.
Yeah, so we'll have we're currently working on it really intensely. It's important to also add, apologies, Chair, that we are also assessing ourselves against, simultaneously to your question of how do you know your unit is safe, against the full CQC framework, and adding in extra things that we feel are relevant alongside Ockenden, so we're bringing them together. So the next board we'll hope to give a full update. Denise, obviously in the committees before, we'll give updates. So yeah, we aim to give a full update at the next board and at every board on this. So yeah, and it's just also to stress, whilst I've got the floor, Chair, is we're working, obviously the LMNS is working very closely, and as Jill said, we're triangulating in every direction with neonatal colleagues in terms of any concerns around safety.
Thank you very much, Heidi. I appreciate it's difficult to put an exact time scale on that, but I'm sure people will be assured it's coming back to next public board meeting. I'm sure it will go through. I'm sure it'll take up a lot of time at quality governance, as it has done, and rightly so, just going forward. I'm sure too our regional colleagues are trying their best to be rigorous in their assessment of how progress is going. Simon.
Thanks, Alan. 2 points. One, the point that Jill made around unavailability of staff is an issue in maternity, but it's probably one of the core issues that we're going to need to grapple with. All organisations in the NHS are seeing higher than previous levels of absence. And so how do we meaningfully and supportively bring that down will be a key challenge as we consider the financial plan. On the Ockenden specifically, both organisations have received a visit from Jacqueline Dunkley-Brent, the Chief Midwife, and her team, which I just wanted to report to the board. I'm not wishing to repeat the other comments that have been made. Her challenge to us was, she pointed out that they are now going back into areas, they're now going back into units that they thought where they had previously fixed or addressed some of the core underlying issues, and cited Morecambe Bay as an area where they're doing work at the moment. Her challenge was, as boards, there is one task that we have to respond to the actions and make sure we reach a level of compliance with those. There is another task to really demonstrate sustainability. And her key word for us that I will leave you with was, how do we get to a level of sustainability? Because that is the issue that nationally, amongst others, she is grappling with.
Okay, thank you very much. It's important that maternity services work together with neighbouring organisations. Of course, it is, there are no safety valves for maternity. You can hardly have a waiting list. And so people do need to be able to respond to whatever arises. And to that, we do need to have a very robust and solidly resolved set of solutions, as opposed to some temporary solutions. So I'm pleased at the work Heidi's leading on this. I'm pleased with the work everybody's doing. Thank you, Jill and others. And I'm sure the reports will be forthcoming. In the meantime, we are clear our services are safe, and we also grateful for the new head of midwifery and the work that she's been doing in this area. Okay, thank you very much. Board assurance framework, Richard.
Thank you, Chair. So the paper as presented demonstrates the reviews that lead executives have taken in Q4 against the NGH board assurance framework and the principal risks therein, and the group assurance framework, which relates to delivery of the dedicated to excellence strategy and the 8 underpinning strategic initiatives. Also to note to the board's attention is the work that the Audit Committee have done, which David touched on in his report under the IGR. There is a deep dive that's been undertaken, which produced some really helpful recommendations around process, around format, as well as around some of the individual risks, but more than anything about how can we bring a process that's unified across the group, that helps both boards really get assurance that we are delivering what we have set out to achieve. So on that, board will recall that for 21-22, we set out with 3 board assurance frameworks, almost but not quite a legacy of NGHs, and Kettering did the same, and the group BAF as presented in the papers. Both audit committees have agreed that now's the time to move things forward. So throughout June and July, I'll be leading a process across the group to align all of the risks under the group board assurance framework, bring back assurance on the process to the June audit committees, and through the committees of the board, come back to the July board with a single integrated process and a single integrated board assurance framework that gives assurance not only that we're delivering dedicated to excellence across the group, but that those risks those principal risks are underpinned by a robust risk management framework across both hospitals, which is a parallel piece of work that I'll be doing over the same time frame. Again, as Heidi alluded to, we're doing that together. We're doing that in both hospitals, but we're also doing it between the organisations so that everybody who works here really understands how risk underpins the delivery of our objectives, both operationally and strategically. I'll stop there. Thank you, Chair.
Thank you very much. Any comments on that? Heidi? Sorry, not Heidi. Sorry, Elena. You don't even look the same. Elena.
Thank you, Chair. Quick question about the group bath risk 01 related to people strategy implementation. It has 15 underlying risks in NGH, CRR, and only 3 from KGH, Corporate Risk Register. From the IGR, Integrated Performance Report, we saw that 3 out of the 6 currently available KPIs have negative variations at NGH. In combination with the feedback which Trust received from staff survey and April Pulse survey, it looks counterintuitive that NGH has no people-related bath risks. By the way, KGH has. So any comments on it, please?
Just hold that thought. We'll add David's comments and then we'll go to David Moore's comments and then we'll go to David.
Yeah, thank you very much, Chair. It's just in relation to the risk scores, and you know, I'm just looking at the Northampton BAF, and evidently we're working towards harmonisation. You see that I think there are 9 risks here in the BAF, and of those, 7 of them have scores which are rated as extreme risk. I just put this to the executive. Do we really think that these are extreme risks, especially in relation to the risk appetite scores that or the risk appetite rankings that we have there? It's just a challenge that I think we should be looking at that and seeing whether what we're scoring is in fact realistic.
Okay, do you want to come back on the process side of that, Richard, or do you want me to go to Mark?
So on the process side of Elena's question, I think there are known and acknowledged discrepancies between the way Kettering and Northampton have managed the corporate risk side of things. So the disproportion in the number of risks on the corporate risk register that underpin the people one, I think, is clear and makes sense to me from a process point of view. But Mark, I'm sure will want to comment more specifically on the people.
Okay, Mark and then Simon.
Sorry, I found my unmute button. Thank you. So you're right, Elena. So I know we didn't get a chance to do it on Monday at the People Committee, but Denise and I subsequently talked about this in our one-to-one later on this week, and I've had a conversation with Richard. This is why exactly in June we need to have a proper go through all of our corporate risks and our BAFs, all 3 of them, in order to come up with a more consistent position, because the risks are very similar in both organisations, and these documents don't currently outline that level of detail. There's also a question about the level of risk, which I know was equally raised in CPC in terms of being at 16, and perhaps that looks more like a 20 given the staff survey results. So we need to get much more coordinated about how we do this. And lastly, as Richard's just pointed out, as you also pointed out, how corporate risks feed into this and how they elevate that risk to one extent to the other, but they have historically been different. It was the first thing obviously that jumped out to me in terms of the people risk not being evident in the Northampton BAF moving forward. So that's why July we've got a whole dedicated session to go through it together.
Okay, thank you, Simon, and then we'll finish with Heidi.
My point was just going to be about system risk. So one of the things that we're going to need to do is to calibrate these risks against how we construct risk at a system level. We've all agreed that as part of the planning round, given the financial challenge, this would be the moment at which normally everybody would go off into their silos and look to secure their own position. Given the financial challenge, we're going to have to work together, and we've agreed that as we understand risk, it is not enough to understand it in an organisational context solely. We need to understand it as a system. And critically, given the fact that there are likely to be trade-offs involved in some of the conversations we have clinical input into that risk assessment, because the trade-offs will directly at some point come back on clinical services. So I think this work is timely, and I would encourage us also to link it to that emerging dialogue about system risk.
Thank you. Heidi.
Thank you, Chair. So David, as we've discussed this and it came up earlier in the board, I think the piece of work Richard and I are doing and across the hospitals around the corporate risk register and the BAF in terms of scoring, we need to do that in the right way. We could very easily just adapt the scores based on, you know, an executive perspective, but we need to take the divisions and the teams on a journey with us. We're trying to drive a culture of speaking up and making sure people have a voice. So we need to make sure we've brought the corporate risk register down from nearly 170 risks to around 120 at the moment. So this is a piece of work that I absolutely agree with you. The scoring isn't necessarily right, but me and Richard are trying to do this in a way that is sustainable and allows the cultural piece of not making it feel like we're simply taking risks off, which other people feel is really important. So we need to get it right on the cultural piece too.
Okay, thank you very much, everybody. I agree with all the reviews that are going on. I agree that having a risk register with too many items on it is just silly. And despite everybody's best efforts, it's been difficult. I agree that we need to think about risk across the system, particularly clinical risk. But I also think that we need to make sure that in our plan for this year, we recognise what our biggest risks are and do something about that as we go forward, rather than go and solve different problems. So let's make sure that there's a relationship between our planning decisions and our clear board assurance framework and the risks to our strategic objectives. So thank you very much, everybody. Annual self-certification. They recommend from the Audit Committee that the board approve the trust self-certification against provider licence conditions. Well, this is just say yes, please. Yes, thank you very much. Excellent. Now, Audit Committee terms of reference and delegation authority. This is to approve the annual report and accounts, and obviously we would wish to delegate that responsibility to the Audit Committee. And we need also to delegate approvals of the annual reports and accounts to the Audit Committee and the quality account to the Quality Governance Committee. So that's simply part of the process of having 2 monthly board meetings and therefore making life difficult. So a natural delegation, which we do every year. Are you happy to do that? Good, thank you very much. The Elective Collaborative Committee, we've talked about this at great lengths. It's a big deal for an acute provider to be given responsibility for the elective collaboration. I mean, there's a lot of my colleagues as chairs around the country going, how on earth did that come about? And mostly they ask that question because in most systems, other people are nervous about giving that responsibility to an acute provider. So it behoves us to make sure that we use that power properly in the interests of everybody, not in our self-interest, in the interests of our patients in particular, and tackling inequalities, tackling the elective backlog, offering mutual aid to other trusts, and so on and so forth. So in order to make sure or to attempt to make sure we have assurance and governance of that, this is a set of terms of reference, and in particular involves the appointment of Elena as the non-exec director to this, along with her colleague, Dr. Llewellyn from KGH as the chair of that committee. Are you happy with those terms of reference and nominations? Yes, good, thank you very much. And finally, the appointment of nominee to the Integrated Trust Board. At the risk of irritating anybody from NHS England who's listening, this is a silly little bit of bureaucracy, which involves us having to do the blindingly obvious, and the blindingly obvious in this case is to appoint Simon as our representative to NHFT. And you will see that I'm asking you to give me delegated authority to object to any other suggestions if they are even more silly than the idea of the process we've had to go through. Are you happy with that nomination? Good, thank you very much indeed. Questions from the public? I have none to date. Is there any other business? No. Oh, yes, Heidi.
Sorry, Chair. I will be 1 minute. That's all we've got. I put in the chat, I should have said it in the clinical strategy, to Rachel's point around prehab and rehab. It reminded me to note that we are having a day and an event at the beginning of July to launch a collaborative way forward on the Cancer Centre of Excellence. And we're fortunate to have Professor Sir Mike Richards coming to join us to make sure that we really think ambitiously, collaboratively, and in the interests of patients. So I just thought it was important to note the board on that point.
Thank you very much, Heidi. I know Mike extremely well, and I'm sure he will give us terrific insights and give us a real sense of purpose and pace about that. All non-execs will be invited to that event. I'm just asserting that, Heidi, I'm sure I'm right. All non-execs will be invited to that event. I don't think we've got a venue yet, but we certainly have a date of the 8th of July, and it will be a large-scale clinical conference. I'd encourage as many people as possible to come to it, on the basis that we need to have a real sense, a real detailed understanding of what our clinicians think about this, and what and the other people in the room, what they think about this Centre of Excellence and exactly how it should develop and how ambitious it should be. It's very important we have a rounded, triangulated view of that ambition. So thank you very much for that, Heidi. That's a really good piece of work, and it's I know it's not easy to get Mike Richards. He's a busy guy. Okay, thank you very much, everybody. Date of next. Can we now pass the resolution to exclude the representatives of press and public on regard for the confidential nature of the business to be transacted? Nods. Thank you very much. That's very helpful. And the next meeting will be on Thursday, 28th July at 9:30 a.m. Back, please, on a separate link for the private board meeting at 1 o'clock. Thank you very much for